because it's not only us who are in this program or in this conference. I think the plenary session that we have in this room, we've got 2 plenary sessions. The first session was supposed to have started at 2 o'clock, which is the impact of fraud, waste, and abuse on medical schemes. And the second one is ethical leadership and prerequisite for growth. And then welcome again. A quick introduction. I'm going to introduce the speakers who are going to give us the first plenary. Firstly, my name is Dr. Setseho, all the way from Free State, Bloemfontein. For those who happen not to know me, there's an opportunity for you to know me today. Let me start by introducing our first speaker for the day on this plenary, who is Dr. Pardon Maluleke. Dr. Maluleke, he qualified as a dentist. He obtained Bachelor of Dental Surgery, 1994. The then Medusa at Medical University of South Africa. He as well obtained a diploma from De Montfort Institution doing bioethics and health law. He's currently a CEO, a Chief Executive Officer at Dennis Dental Information System. Or clinical executive, sorry. Sorry. I said, you know, clinical executive. He's also an honorary lecturer at University of Witwatersrand in Community Dentistry Department. He's as well the chairperson of BHF Dental Advisory Forum. So he had it all. And then our next speaker in the same discussion, we've got Ismail Mohapi. Ismail Mohapi holds a postgraduate legal qualification and strategic leadership. He is a senior manager on operations, risk at GEMS. He's as well employed or is as well assisting at a different managerial position in health administrative businesses, where he provides advisory and several advisory and coordinated fraud risk management on different administrative level. He has over 20 years of law enforcement and risk management experience. So there's experience here, 20 years. So if you're a dentist, more than 20 years, if you're a dentist and you are 20 years, and then you must know that you are equally to the same as the experience of Ntate Ismail Mohapi. Ladies and gentlemen, my colleagues, the 2 colleagues, they will be discussing the following. 1, how fraud, waste, and abuse affects a member's contribution, auditing of claims, identifying triggered factors. Those are the key elements that they are going to discuss today. And hopefully will be listening attentively. We'll have an opportunity for Q&A, question and answers later after their presentation. Thank you. Can I give over to Dr. Malu? Oh, okay. Raish, yeah.
Yeah. Thank you. Yeah. Good afternoon. We as GEMS appreciate the opportunity given to us by DPA. And maybe I must just say that I'm hoping that this is a safe space, a safe environment. I'm discussing a very sensitive topic, fraud, waste, and abuse. And I've heard the minute when one says fraud, we know Section 59, GEMS is discriminating against blacks, Indians, and coloreds because they say they are fraudulent. Yeah, but anyway, that was in January, and I'm not here to defend the report or to defend the stance, but I'm here just to build relations. I'm here to explain, as the chair has indicated, the impact of fraud, waste, and abuse on medical schemes. And I'm also here to explain in terms of what our processes entails when we are managing the risk of fraud, waste, and abuse, and how does GEMS treat this concept of fraud, waste, and abuse. So I'm hoping that after this session, I'm going to learn a lot from providers. I must say, from our algorithms, we deal with numbers. As I stand here today, I'm colorblind. I don't know who's in the room. I don't see color. I see practice numbers. But behind practice numbers, there are individuals, there are practitioners, and which we understand, guys, you spent a lot of years training to become dentists, and to be told that your fraudsters is demeaning and hurting. So this is just an opportunity for us just to indicate. I've got a message also from the board that from a Section 59 perspective, we are working with the council, we are working with the panel, and we're working with the association in terms of dealing with that report. So this is one of those steps. So I'm going to be dealing with this first section, which is basically fraud, waste, and abuse. And the other three sections, Dr. Maluleke will deal with that. Now, from a global perspective, I think it's very important that one understand the impact of fraud, waste, and abuse. In South Africa, we've not yet quantified it. Some speak of about 22 billion, but it's approximately between 5 to 20%. And it's experienced globally. As you can see, about 600 billion is estimated to be lost due to fraud, waste, and abuse. So we are part of that. You would have seen reports saying South Africa is about 22%. GEMS pays about 34 billion a year. If you take a conservative approach, how much is lost out of that 34 billion? We're looking at about 0 to 10%. So when we do engagements, we try to not to recover, but to change behavior so that that money is not lost. Now, I'm a lawyer by profession, but I think I'm not trying to teach you what is fraud, waste, and abuse. But the approach that we employ at GEMS is that we try to distinguish which incidents are fraudulent, which ones are waste and abuse. And I've dealt with so many disciplines, and I've learned that when you are trained, you are not told how to submit claims at medical schemes. Most of the things that we find is finger errors. And I think Dr. Maluleke is going to go in there in terms of coding, things that you do not know, which you rely on third parties who process your claims. So from our side, we can take fraud plain and say, I'll give you examples of what we deem as fraud, what we deem as conduct which can constitute waste and abuse. But there's a fine line. And the differentiating factor among all these three elements is intention. What is the intention of the perpetrator when he submits a claim to the medical scheme. Does he want to defraud the scheme? Does he want to make extra cash? Does he want to defraud the member? At the end of the day, the money belongs to our members. Now, these are some of the tactics that are employed, which we have seen, and we've got evidence to this effect. There's one of code manipulation, I think, which we'll be going into later. Submitting accounts for services not rendered. You know, you did not see patient X, but you submitted claims because patient X was supposed to be here in 6 months. Merchandise substitution. We know this, people are getting groceries, pots, you know, in terms of medication, dispensing of generic medication. And from an abuse side, is billing for unnecessary service, upcoding and bundling of codes to get more payments, excessive charges. And then maybe waste. And we're using general examples, not specific to dental, which I'm going to leave to Dr. Mondlek to do. Over-servicing, unnecessary admission, high cessation rates. So we, on a daily basis, we see scams. And you will be shocked in terms of things that we see. Now, who are responsible for this? I mean, from a service provider perspective, they will be responsible for submitting those false claims, irregular billing of codes, duplicate claims. You know, members come in November, October, benefits are depleted. I will put it in January. Our system is going to show it. It's on the 2nd of January, you saw about 90 people, 90 patients. And when you ask questions, but they were here in October, November, benefits were depleted. What are you missing there? Remember Regulation 5, the claim, the date of service, it affects the member's benefit. So those are the things that we look at. Now, from a member perspective, I've got Mapules, my cousin, doesn't have a medical aid, go to Dr. X, use that thing. Cut farming, some sells it. There's a lady called Poppy in Wheatbank. As you know, GEMS, we cover everyone. We can cover a child next door, as long as you can indicate that that person is financially dependent on you. Mapule registered about 26 dependents. Mapule is a cleaner at a hospital, and she put all of those people there. You remember, GEMS did not underwrite before. So people joined, went to hospital for a procedure, she charges 10,000, and then they exit the scheme. And we caught it probably after 8-9 months, the scheme. So this is what we call cut farming. Now, from an employee perspective, yes, Dennis, employees of Dr. Maluleke, they can also submit false claims on behalf of providers. They can also channel member refunds to their accounts. We found of those people. Now, brokers, as you would know, also false medical schemes policies, non-disclosure of applicants' pre-existing medical condition, because you want that person to come in for a specific procedure. They lie about it. 2-3 months, the person goes in, do the procedure, and they leaves. Now, the most important one is collusion, which are hospital cashback plan, hospitals colluding with independent allied service providers. In KZN, there's a specific hospital. You know, this one thing, growing up in the township, I know Black people don't like hospitals, but KZN is different. People go there in buses and they wait in the cafeteria waiting for a bed to open. We had to send in nurses to go and manage each and every admission in hospital management. Some even speak to the doctors, do a small procedure. What do you call this thing? Inyani. Yeah, and then take out something so that I can stay longer. But when are they benefiting? They're hitting clientele, the likes of clientele and the likes, because it's hospital cashback plan. So they're cashing up on these things. So that's how the collusion works. And even the main one is a syndicate. Those who operate in the Pretoria North area, you are supposed to be seeing almost 80-90% of GEMS members residing in Pretoria North wearing hearing aids. But they're not. We know they're not. But they get 1,005. They even call, they say, why is this guy claiming 9,000 and I'm paying 1,500? They complain because they feel, you know, it's defrauding me because he got 9,000. And unfortunately, some of them are in hospitals. These are nurses, these are teachers. When we go there and speak to them, they say, look, I no longer use the hearing aid, I gave it to my brother, or I'm healed, I went to the hospital, and all those type of things. But then these are the type of syndicates that we know. We have a current syndicate that we're currently operating. They've got a GEMS member list. Irrespective of where the members are, members get, to join the scheme, you pay 3,000 and you get e-wallet every month of about 1,500. So claims come from different disciplines, all disciplines. So it's a horror story, but that's what we're dealing with. Now, how does that affect us? I mean, obviously, it affects costs, it affects the utilization. So we think people are using the our reserves suffers in the sense that now we have to increase the benefits because everybody's going there. So hence I said earlier that between 5 to 20% of our revenue is impacted by this. Summer says, if you can look at the bullet point 4, approximately about 150 of a member's average contribution goes into fraudulent activity. And that was back in 2002. So you can imagine with inflation and the likes, how much goes into there. So member suffers as a result. And what it does to us is that now there's a specific daughter that a dentist that I'm dealing with, and he tells me, hey, this barrel of yours, I bought a 2 million rand machine, that X-ray, exam and so on. How am I supposed to pay if you guys' benefits are like this? So we had to limit our benefits, and this is because of this. Now, why is it so easy to defraud the medical schemes? I mean, the tariffs that I spoke about, they are complex. I mean, you need a specific person to do your billing. The codes that Dr. Muleka is going to be talking about, I think I've been in the medical industry for probably 10 years. I still don't know code 8112. You cannot pair it with 115 or 116. So those are the things, and it's very easy. But I can tell you, there's what we uncovered. We've got people who hijack your practices, especially for those practitioners who decided no longer to be in private practice and go into government. Your practice number still remains with BHF. We've uncovered more. There's a guy in Kososhanguve. He will steal your practice and he will submit claims on your behalf, and you would not know because he will change everything. That is identity theft. So as much as it's complex, there are people who knows these things, how it's done. So there's millions of claims. I mean, we've got about almost 40,000 active providers, 67,000 diagnosis codes, 87,000 procedures. On a claims run, we pay, I think for this discipline alone, so far we've paid about, I would say we've paid about 32 billion to about 36,000 service providers. So you can imagine when we have 2 runs, bi-weekly. So there's an opportunity to do this. And we only have a few hours for our system to catch outliers. Because some submit the claims, they know the run is on a Friday, they hold them on a Thursday evening. And we're gonna miss them. So in all instances, we have to run, we run behind. Now, as I've indicated, members, and you hear them. These are my benefits, I've not used them. Let my cousin go in. Or they give me cash. I don't know if you guys have experienced instances where a person comes in and say, I demand cash. But we have heard those stories. Take this medical aid, I'm paying it for it every month. Because members do not understand how medical aid works. Medical aid is just like society. And I'm talking to people who understand society. We combine all our money so that we can use it for burial and the likes. Similar to medical aid. That's how it is. We keep your money, and then the one that is not used go into reserves. which will serve for most expensive procedures that will probably come at a later stage. So those are the type of things. These are some of the indirect costs or associated costs related to fraud, waste, and abuse. It can drain us. Who remembers the news articles in 2016? Government employees medical scheme about to go past. James hour. Everybody was worried because everybody is claiming from James. We were going down, guys. I promise you, we were going down. And what we did, we developed something which we call the Claims Management Forum. We had to relook at our system. You remember the first thing, James, how it was developed is that we wanted to show that this is something that can work. So there was not too many controls that we put in place. Or submit claims we used to pay. And people, this is a cash cow. This is what happened. So we had to put those controls in place. This is why we have the likes of Dr. Mullen, to put these systems in place to manage claims. But as a result, they created noise. Now, the other thing is significant legal costs. If I tell you how much money we lost and which we're trying to recover, the unfortunate part, I don't know what people do with the money after they get it. You can't recover, you can't take the car, it's gone. I don't want to talk about people who are from Nelspruit, but only News Cafe in Wokwa. There's a guy who got 5 years suspended sentence. I couldn't get the money. It took 5 million. 5 million. And members came and testified. So, yes, he had a GTI 32, but there's no car, there's no money, there's no house. So we're chasing and we're losing. This is not our money. This is members' money. So I've got so much debt that sometimes we have to write off. Now the other one, the last one, which you guys are not happy about, is the removal of some of the benefits, because we could see some of the benefits that have been misused, and which has a serious impact. So that is my story. I hope I had more time to share the horror stories, but I hope you would understand. One of the things that I want to tell you is that we are looking at our processes. When you receive that letter to say that we're requesting X-ray, X-ray, and please, you've been selected because you're an outlier. We had an engagement with another provider. The NACPA was there, and he mentioned, my patients love me. Banrat, they love me. That's why everybody comes to my practice, which we thought is, for the type of service that you are rendering, is not clinically possible. And the quality of care, that for you to be seeing 90 people in a day and in different areas of the province, was worrying. And we spoke to him and said, look, every time our system is going to flag you because you're going to come out as an outlier and we're going to engage you to validate services. Please, guys, it's not that we're saying you're fraudulent. My thing is that, please, what we've done now, we've looked at the response time. The 7 days, if you cannot meet it, keep up by extension, because we understand you're busy. But this is, why do you want to do this? I'm scared they're going to cut my direct payment because of, hey, now they've flagged me. How does that operate there? We no longer operate in that sense. So please be cooperative. We want to partner with you. We want to learn. We heard all the stories at the Section 59, all the horror stories, what medical aid are doing. We have also people who goes on the ground that sometimes interview some of your patients. Your patients will be asked, do you know Dr. So-and-so? And the patient rightfully will pick up a phone and say, Dr. Khan, why but phone? And I'm at work, because they're irritated. Why is James validating service? How will I know what grade 6 but again, feelings? People are afraid of needles, but work around 9 feelings at the one go. So why is that? So we'll ask those questions. You understand? So member will ask, why put those things? Those are clinical things. I don't know anything about it. So we ask these questions. You know, the other things that you look at the use of golden lace and the likes. the star, the L shape, and all those things, but we don't pay for those. You know that. So, I remember I didn't pay money. Gold. So, what happened? We will ask those things. And the other things that people I want to help. So those are the type of things. Yeah. So when you receive that letter, please cooperate. If you have challenges, I mean, we're going to share our numbers. Call us. We are available. We want to hear. The treatment that we might have given to you or your colleagues, please bring it to our attention because we want to change. It's not that we are saying we're wrong, but we do not want to be perceived as a scheme which is discriminating against Blacks, Indians, and Coloureds. And GEMS predominantly, as you would know, the dynamic setting. We rely on data, we rely on hotlines. More Blacks go to Black providers. You understand? They don't go to Santins. So those are the things. So, yeah, I think I will end here. And then I'll take questions at the later stage. Dr. Moleke then can proceed with the next section. Thank you.
So normally Ishmael, when he gives an example of a provider, he normally picks Malamulele. So you'll say, for example, in Malamulele, you'll find that you go to a dentist and do ABCD. So it's like Julius Malema. Julius Malema, when he wants to give an example and he knows that Floyd is next to him, he'll say Mahonis because Floyd is from Mahonis. So Ishmael does the same. He picks Malamulele because I'm from there. But I'm glad today that he never used that example. But firstly, and good afternoon, ladies and gentlemen. I want you to echo what Ishmael has said, just to extend our sincere gratitude to get this opportunity to engage with the broader membership of DPA. We normally meet with Dr. Twala and Dr. Marishal twice a year and discuss different issues. So we really appreciate this opportunity. But secondly, also to say thank you for your continued support in terms of provision of oral health care services to GEMS members, especially during this COVID time. While some of us are sitting comfortably behind our desk and laptops, I can imagine what you actually went through, especially during the first, second wave, and third waves. And I know most of the time when you talk about healthcare providers and wants to say these are the heroes, we focus more on those who are in hospital and assistant doctors. But you guys were also in the firing line, especially considering that you work in the oral cavity. You are very close to, you actually came face to face with COVID. And I think thirdly, before I go to the boring stuff, to say to Dr. Twala and DPA that I'm actually jealous. I'm actually jealous of DPA. He knows my history, Dr. Stefan knows my history. That during my times, DPA was very boring. I'm jealous to see the growth that under the past few years, how far you have grown as an organization, especially not necessarily in terms of quantity, but in terms of quality, value add to members, the kind of stuff that you actually focus on, firstly. Secondly, the relationships that you build with different stakeholders. Now, and obviously we know, when we go into healthcare reforms, whatever shape and form that is going to take, DPA will be very, very relevant and very, very important. And Ishmael, as Ishmael said, we here to build relationships. GEMS engage with different organizations to try and build relationships and also try to extend that to individual providers. Now to the business of the day and the boring stuff. So Ishmael has given you an overview of the impact of fraud, waste, and abuse. I'll try to bring it closer to home in terms of what's relevant to us in terms of what you do on a daily basis as dental practitioners. And in doing that is to try and answer some of the questions that we might have, especially related to the processes that we employ when it comes to the issue of fraud, waste, and abuse. Then I'll talk to some of the coding irregularities that we pick up on regular basis as we do, our internal review. As Ishmael said, we try to chase claims after they've actually occurred. So we review and see what we actually pick up. But lastly, I'll share a few examples of outliers that we actually have picked up. So I think one of the most pertinent questions is how do I get identified as a provider to be engaged by GEMS? So we rely on 3 issues. The first one is our internal reports. In the next slide, I'll break it down in terms of these reports. We also rely on queries. In actual fact, the bulk of the issues come from queries. Again, I'll unpack what we actually refer to. Thirdly, is the managed care risk process that we use for tooth charting. So for every claim that comes through, for every beneficiary or patient, we store that history per tooth. And when claims come through, the system goes back and checks what treatment has been done. And in certain instances, then it actually throws out irregularities. And then based on those particular irregularities, obviously then you will be identified if we pick up some of the things. And the most common type of problem is treatment on teeth extracted. We pick a lot of claims where practitioners submit claims. When the system checks, that tooth has been extracted by Dr. Tseo. But Dr. Sibui wants to do a root canal treatment. That's the most common problem that we pick up when it comes to the issue of tooth charting. And obviously then your restorations. So in terms of claims review, and again, as Ismail said, so we chase claims after claims for care services provided, and so much money has been paid. Then you go, then yeah, I'm off. Should I shout? I hope I did not press anything here. Did I press something? I think they just died out.
Testing.
Yeah, so it's either we do them on a weekly basis, monthly, or quarterly. That's why at times you'll find so Ismail suggested that I shout. I'll try to come more central. Or I can talk. Yeah.
So as I said, it's either we do the weekly, we do the monthly, or quarter. That's why I try to find out who have provided services in January. And it just comes to you in September and say we have picked up these irregularities, because that report only makes sense after a certain period of time. A claim on few patients doesn't make sense, but when you build a trend over a period of time, it shows you exactly what's happening. Now,
Come again. Okay. Okay. Let me
what I want to highlight here, what Ishmael also spoke about, is the issue of the practice number. So when these reports come out, it doesn't say to me, you know, I'm dealing with Dr. A, Dr. B. It only gives us practice numbers. So at that point in time, I don't know what we're actually looking at. I don't know where this particular practitioner is from. We don't know who he is. We're only looking at an outlier based on practice numbers. So that's the first identification of this. Members will complain. Members will call us and say, I've got a claim from Dr. A. Firstly, I don't know him. You can say, I don't know Dr. A. Or I know Dr. A, but the service provided, I don't remember. I don't remember getting any feeling or restoration. He or she only cleaned my teeth. And the issue is, patients are getting educated, and we want our patients to be educated, because it also helps us in the sense that, you know, when we talk to them, they understand exactly what we're talking about. So they know the kind of services that they've received. If they haven't received any service, they'll call us and say, I don't remember getting any feelings. But thirdly, is providers. So Dr. Sbuye, as I said, wants to do a root canal treatment, but the system says Dr. Stewa extracted that tooth 2 years ago. And Dr. Sbuye knows he's got an X-ray. X-ray shows tooth number 26 is there. Yeah, I can show you that this tooth is present. What do? Do we deny Dr. Sbuye benefits? No, we don't. If Dr. Sbuye can prove if Dr. Sbuye can prove that tooth number 6 is present in the mouth, we go after Dr. Stevo. We go after Dr. Stevo. Dr. Stevo, we've got a patient A. Dr. Sbuye wants to do a root canal treatment and is going to prove that tooth number 26 is in the mouth. Then Dr. Stevo needs to account. We pick up a lot of issues related to teeth previously extracted. But related to providers again, providers tell against each other. Providers will say, I've got a problem. The dentist up the street does ABC. And all my patients are going there. These are not stories. These are real things that are happening out there. But lastly, in terms of queries, obviously we also follow up on anything that comes from the HPCSA. And recently, as you know, there have been a lot of BOCAS practitioners in different areas that have been picked up. So we also track and see what's actually happening out there. Now, this is some of the statistics that we picked up from 2020, just to share in terms of our engagement with different practitioners. And this will illustrate the fact that, and as we always say, it's not all providers who are fraudulent or who are picked up as fraudulent. It's just a small number, but the impact obviously is too high, as Ishmael has mentioned. Now, just to illustrate, in 2020, we had 3,998 dental practitioners claiming from GEMS. Now, we did profiling of 1,797 providers. So the rest, nothing happened. 1.7 were profiled. Now, out of those, only 18% showed initial concern. There were few things that we wanted to look at. So that's 18% out of 1,797. Now, after having that detailed profiling, 60% of that made sense. So we're drilling down, we move from 3.9 to 1.7, and then we said 18% of 1.7. And out of that, only 40% was still a concern. So one of the things that we do as part of a risk management is, as Ishmael said, is the issue of X-rays on records where GEMS will request records from providers. And that was requested only from 194 providers. Out of those, it's only 13 providers that led to further analysis. So we're moving from 3.9 to only 13, which is around 0.3%. So by and large, it shows you that in as much as the impact is high, we don't sit and engage with a lot of providers. There might be background work that is done, but after that, some of the things we leave them because they are not of concern. Now, Ishmael mentioned that in certain instances, when we say to you, let's talk, please don't run away. We had a discussion with around 24 providers. And normally when I know Ishmael might kick me, but here's the thing. When we say let's talk, in most instances, what we ask you to do is to have a discussion with us. I'm a clinician, I'm not a lawyer, I'm not a fraud investigator. When I engage with a provider, it means I'll be engaging with a provider on clinical matters. So when I say let's talk, let's discuss what we pick up and try to change behavior. He emphasized the point that what we're trying to do, change behavior so that we continue building relationship with providers. So we had 24 of those, and in most instances, what we do, we agree in terms of monitoring. So we say to you, we picked up A, B, C, D. This is how to correctly apply these. Going forward, please check on that. And then we monitor, we move on, then life goes on. As simple as that. So please don't run away when we say let's talk, let's engage. Now I'll share with you few coding irregularities that we pick up that were actually of a concern to GEMS based on claim. The first one was the use of tariff code 8101 versus 8104. So we know 8104, it's mainly for specific, consultation for a specific reason. So what we have picked up is that in certain instances, providers will charge 8101, and then within a period of 6 months, when they haven't completed the initial treatment plan, when somebody comes back for procedures that require subsequent visit, for example, root canal treatment, placements of dentures, then they'll continue charging for 8104. So you finish your treatment plan, it's only then that you can charge 8104 if a patient, or only if a patient requires specific consultation. The second code, The second code is the use of what we call sedative filling. So in most instances, you'll find that some practitioners will use this under your restoration. The third code is problematic, the use of periodontal screening. You find that in certain instances, there's high utilization, but when you request records, there's no charting. So we know 8176 requires 3 clinical indicators. You need to do your probing, you need to chart it. You need to do your plaque index, you need to chart it. You need to do bleeding index, you need to chart it. They were not charted. It means then you claim for services that were not provided. When they try to chart, they will only chart your periodontal probing. The other clinical indices not indicated. So please, let's pay attention to that. Fourthly, the use of desensitizer per resin versus your medicament. So providers will use your medicament, but instead claim for resin, because obviously it attracts higher benefits. The other code that was a concern was the use of provisional splitting. So there were certain practices where for each and every scaling and polishing, it's followed by provisional splitting. Yep. 80 to 90% after scaling and polishing is splinting. I've been asked to speed up a bit. Then we've got the use of diagnostic photograph. Now, James only pays this 1 if it's used for orthodontic treatment. 2, if you want to show any pathology, any lesions beside your routine education of your members. If you routinely use it, yes, use it, but don't claim for it. Yes. James doesn't pay when you use it for educational purposes. And then fourthly, the use of ICD-10 codes. So ICD-10 codes, they're diagnostic in nature. They give us certain information in terms of the burden of disease. So what happens out there is that we pick up any diagnostic ICD-10 codes that comes to mind and throw it. Now, when the scheme goes back and tries to design benefits and pull out the ICD-10 codes, it gives a skewed burden of disease. So let's try, please, to use the appropriate diagnostic ICD-10 codes. I won't talk about the issue of golden lace. We know what's actually happening. This is mainly a problem with the other discipline. But there are still few dentists who provide golden lace, and then after that, as Ishmael said, members are told that don't worry, we'll see what to do. But after that, what you do, that you get claims for fillings, which are not done. I heard somebody said, yeah, I hope you're going to change your mind now. So as you receive records, we also pick up things, and obviously this is a preserve of HPCSA. These are ethical conduct issues where we feel that records are not kept accurately. Information is removed. In certain instances, you use correction fluid to alter records. We squeeze lines, additional lines between lines. Somebody came on the 23rd and then on the 27th, and then all of a sudden in between, you squeeze a line and write services. I'll skip this one and go to this one. This is also a concern to the scheme in the sense that we're picking a high number of dental practitioners who are providing services where there are no x-rays taken. So to break it down for dentists, we picked that around 13.4% of dentists are providing services. There are no x-rays whatsoever, 0. Dental therapists is much higher at 59.3%, and oral hygienist at 74.2%. I remember an engagement with one provider, and he said to me, "You should be glad that I'm not taking X-ray because then I'm saving the scheme money." Then it raises questions in terms of the quality of services. I think as clinicians, we know to diagnose, interproximal caries, the extent of caries, the issue of periodontal disease, you need to take X-rays. We actually break this down further into different provinces. And unfortunately, my province, it's higher. Most of the practitioners in that particular area, not necessarily Malawi, but the province itself, don't take X-rays, followed by our neighbors, Mpumalanga. And then we've got Northwest, followed by Gauteng. Now, if you break it down into patients, Mpumalanga leads the pack. Around 54% of patients were treated without X-rays. 54% of patients were treated without X-rays, followed by my province again at 44%, and then Eastern Cape. This is a concern, and I'm sure you'll agree with me. Now, lastly, just to share a few cases that we looked at. And again, in this particular one, there are no practice numbers. So we were concerned with this particular practice because when we looked at cost per patient was much higher, which is just an outlier. At this point in time, the practice is an outlier. The practice is not fraudulent. And in such instances, we want to engage to understand how your practice is different from the others. But what we did, we checked for X-rays. This practice is providing multi-surface, multiple restorations. I'm talking 8370, 8369, all 4 quadrants, but no X-rays. So you're saying to me, you're treating patients who have high caries, but you're not taking X-rays. That's why we became too concerned about this practice. Now, maybe to move to the right. So we compare this particular practice with the peers. So the orange color is the peers, and the blue one is the provider. So firstly, we looked at the number of patients who are receiving more than 3 fillings. So you can see the practice is almost sitting at 80–90% of the patients are receiving more than 3 fillings, compared to the peers, which is sitting at around 20–40%. When you go to X-rays, zero X-rays. Number of patients walking into the practice and walking out with fillings, 100%. Everybody that walks in comes out with fillings. But that not on itself is not a problem. The problem is that there are no X-rays and you're providing multi-surface restoration, multi-surface restorations. Okay, case number 2, almost similar case. Again, we're concerned with cost per patient. Of course, there are other practices that are outliers. But when we zoomed into this particular practice and look at these measures, firstly, we looked at the percentage of patients who walk out with 5 or more than 5 fillings. It's almost 80–90%, compared to the peers, which is almost 10%. X-rays, 0. Patients walking out with fillings, 100%, compared to around 70% with the practice, with the other practices. Periodontal screening, 8176. Again, here's an outlier. No practice number. I don't know who I'm dealing with. I only see a dot here that says there's high utilization here. You break it down into age, children under the age of 16. Again, this practice sticks out. Of course, it's got a friend here. But you can see the other providers are at the bottom. Other practices are at the bottom. So there's no targeting of any individual providers. We base whatever we do on these numbers. application of desensitizing medicament. I mean, look at this. Here are the other practices. The rest of you are sitting here. The rest of you are here. Yes, Dr. Maluleke here. What are we supposed to do with Dr. Maluleke? We say to Dr. Maluleke, let's understand why your practice is different from the other practices. So colleagues, in short, this was to share with you some of the things and how we actually do it. And as Ismail said, to try and answer some of the questions and build a more relationship with providers. Okay, intraoral images. Again, you can see this practice is just alone here. The rest are at the bottom. We're not concerned about these ones because they are fine. But this one is sitting alone. And when you see such an outlier, you need to engage and understand. Yeah. Thank you, Chairperson.
Colleagues, thanks for your time. Dr. Maluleke and Ishmael, I think, as I said at the beginning, we were running against the time because of, this thing you started late is affecting us a lot. And more especially when you are in a hybrid, both physical and virtual. Now we are affecting people who are overseas to inform them that they need to come out and do the presentation. Without waste of any time, I would like to take to give both of the two gentlemen to thank James for presenting. One will take that wine. Yeah, it's wine. So that you don't see the outlier. Technology is very interesting. Because of time, and maybe we'll just wait for the next presenters, then we'll take questions later. Then we can chow a little bit on our tea time. I think if that it is right. Our next, I think if everything is okay, Dr. Twala, is it ready? Okay, maybe let me do quickly the introduction. Okay, video. Okay, colleagues, we will be I'm quickly going to do the introduction of the two gentlemen, two doctors, Dr. Raj and Dr. Alesta McCalvey. I think most of you are familiar to the two gentlemen. And then Dr. Raj is currently a dental director at Dental Protection, and he holds the qualification as Bachelor of Dentistry. I don't want to mention years now because of people, they get afraid when I talk about the years. A fellow at Forensic and Legal Medicine, a fellowship at Internal College of Dentistry, postgraduate diploma in education, and Dr. Alesta, my friend, I hope you can see me there. Bachelor of Dental Surgery. He has well obtained an LLM in healthcare law from University of Wales. The two gentlemen are going to talk about setting an example in ethical leadership, discussion about ethical fingerprint, ethical faith, communication skills, social media advertising, culture, and impact of standard of care. Let me take the opportunity. We will be watching them attentively from the video. I can hand over now. Thank you.
As dental professionals, we dedicate our lives to protecting our patients' health and well-being. But who looks after us? Dental Protection does.
Their expert dental legal team are dedicated to protecting us and providing reassurance when we need it. Dental Protection was started by dentists for dentists. Their unparalleled expertise gives me confidence, and I know they will support me throughout my career. And because they are owned by members like me, I know they will always put me first.
No one is in a stronger position to protect me if I need advice or face any challenges in my career. And they help with more than just patient claims, including issues such as unwanted media attention, criminal proceedings, ethical dilemmas, and regulatory issues. If I'm worried or in trouble, I know I can call on them and speak to their team of experts in an emergency at any time.
But it's not just about if things go wrong. The team at Dental Protection helped me stop problems arising in the first place by helping me look ahead and understand risk for myself. I've got access to a huge range of online courses, seminars, and podcasts just a click away, plus workshops and other CPD accredited programs too.
Discretion means that Dental Protection are flexible and adaptable. They treat each incident on an individual basis, giving me access to protection for a wider range of situations. And Dental Protection gives healthcare professionals like me a voice, representing my interests to the government, policymakers, and professional bodies.
So whether you're an existing member or part of the next generation,
Dental Protection is here for you, for me, for us all.
Protecting your career and reputation, now and into the future.
I trust everybody can see the screen. We're just waiting for my friend and colleague Alistair to do the introduction here.
Yes, I'm here, Raj.
Thank you, Alistair.
So they must talk.
I just switched on now. Once it's plugged in, it automatically needed to play. Okay.
So
They
we
say
should be
something.
hearing the sound.
Yeah. Oh, it's already playing. No? It's not a video?
Let me see.
Hello, good afternoon. From the UK. I hope everybody can hear us. It will help.
Let them say something.
Is the laptop sound on? That's also another.
I put it on.
Maybe. So nice. Just quickly go back. Sorry. Go back to there. Just want you to minimize and then higher so that I can hear it. Maybe it goes straight. It says HDMI. If it's speaker, it's coming through here. So it needs to be on HDMI so it goes through our speakers. Yeah. That's what I know. In your settings, you're also the same thing.
That's also set.
Hi, Dr. Oh, there you are. Please speak.
Thank you very much. And good afternoon, everybody in Pretoria and at home. And can I just say it's a huge honor for Dental Protection to be invited to speak at your Congress. We're coming live from the UK, and the wonders of technology have allowed us to join you today. Those of you who are at home and those of you who are face-to-face at the Congress. So I'm sharing this talk on ethical leadership with my good friend, Dr. Raj Ratan, who is the Dental Director at Dental Protection. My name's Alistair McKelvey. I'm Head of Dental Services for South Africa. Our strategic partnership with the DPA is relatively new, but my relationship with DPA is founded on a long-standing friendship with your President, Dr. Twala. And I saw a lovely photograph of Thabo with Zodwa earlier on this morning, so it looks like everybody's having a great time. Timing is everything, and today Raj and I are competing with the distraction of a very big soccer match in the UK, which any who love soccer will be interested in. It's Manchester United versus Manchester City, and it's not going well for United. So we'll hope you'll watch that game later and enjoy the next 45 minutes with us. We're going to talk about ethical leadership in dental practice. And if Raj can just click the next slide on. Thank you, Raj. Before I invite Raj to start the presentation, I think it's important to tell you that Dental Protection is the world's leading protection organization for oral healthcare practitioners. We provide indemnity solutions for the whole dental team. So it's not just dentists that need protection. Therapists and oral hygienists also create clinical and ethical risks, and we have indemnity solutions for you as well. At the heart of our business is a philosophy of supporting safe practice and helping our members avert problems from happening in the first place. You can see our commitment through the learning resources we offer, including a host of professional development courses and ongoing learning and development opportunities, very much like this talk today. My colleague Zodwa Mahalangu is with you today in Pretoria. If you need any information about indemnity with dental protection, please talk to her. If you're at home, you can find all the information you need by following the links on the DPA website. So enough of that, let's get started with the talk, and I'm going to now hand over to
Alex,
Raj.
thank you very much
Raj.
indeed, and may I add a very warm welcome to all of you, and thank you for joining today. I'm sorry that we can't be with you in person. I think one of the great joys of our profession is that our collective aim to look after patients and to put the patient's interests first is what binds us throughout the world. So I do hope an opportunity will arise at some point, hopefully soon, for us to have and extend some of the discussions that you're going to see in these presentations on a face-to-face basis. So in terms of my own presentation, we've split our time today into sort of two presentations. I'll be doing the initial one, and then some of the themes that I'm going to mention, Alistair will pick up in the second section, which will have a little bit more of a practical focus in terms of how we actually go about developing leadership skills and so forth. So for my part, I'm going to do an overview today. And, I've always looked at leadership as a sort of a layered entity, if you like. So my approach to it has always been to look at it in the context of different situations. So today, for the purposes of today, this full presentation actually has 7 layers to it, but we don't have the luxury of the time today to deliver the 7-layer version. So I've selected sort of what I call the 4 layers of leadership for the purpose of today. So we're going to have initially do a short introduction, then we're going to look at the business perspective in the context of general dental practice. We're going to look at some research and references, which will give some ideas, which I hope will give you some ideas in terms of how you can grow your business from a leadership perspective. We will look at some ethical considerations, and then I will finish off with some personal reflections. So in terms of my own experience, I've worked at dental protection now for well over 25 years. 20 of those years were as a 1-day-a-week dental legal advisor. And then since 2016, I've been in post in my current role, which is as the dental director. During those 20 years on the 1-day-a-week commitment, my career was made up of really 3 elements. There was the dental legal part, there was some postgraduate education involving newly qualified dentists, and the rest of my time was spent in clinical practice. And my experience of leadership really came from 2 areas. It came from my own practice, where I worked for 28 years. And during those 20 years, we grew the practice considerably. We employed many staff and dentists over those years. And at each, what I would in my mind call a change point, whether we were refurbishing the practice or we were reconfiguring the team, or dentists were leaving the practice to go and develop their careers as specialists and so forth. But at each of those change points, there was an opportunity to develop the practice further, and that's where the leadership experience comes in. So I will finish just with some personal reflections as we get to the end of my presentation. Now, the first thing I want to say is this is a quote from a paper that was published in the Journal of Dentistry exactly a year ago, November 2020. And I'll just invite you to read the quote for a moment. And what it is actually emphasizing is that leadership, first of all, only takes place in a group setting. It's not a solitary activity. There is something, I guess you could say, around self-leadership, but in the main, what we're talking about today is a slightly bigger picture in terms of the role of the leader in a situation of a group setting. The Journal of Dentistry carried this paper, and the outcomes of the review reinforced that actually there isn't an awful lot of information available that is in the context of dentistry. Now, if any of you have heard any of my presentations before, or you've looked at some of the editorials that I've written in our publication Riskwise, this notion of contextualization for me is very, very important, because principles and ideas often work in the context of the setting. I don't think there are any absolutes in dentistry. You can take ethical principles, you can take ideas and management ideas, and they all work slightly differently according to the situation. So that's the first thing I want to get across to you. So what that means is that when we discuss leadership in dentistry, all of us have this challenge of how do we approach it? What do we do? Is A better than B, or is B better than A? And the only way we can actually draw the conclusion is through the experience, and certainly through wider reading. So for me, it is about a broad-based reading and then picking up ideas and thinking, actually, this is an interesting concept. There is a way of applying this in dentistry. And that's the approach I've taken to today's presentation. So let's just start now with this concept of, the business of dentistry. And if you ask most people and say, what is dentistry about? It's about patients, it's about teeth, it's about competence, it's about technical skill. But I want to go back to absolute basics. And in the commercial marketplace, there are basically 3 types of goods, if you like, that are available to consumers. And, our consumers we call patients, and that gives the relationship an ethical bond, which sometimes doesn't exist in other enterprises. And those 3 types of goods that we all purchase as consumers can be divided into goods with searchable characteristics, experience goods, and credence goods. If you wanted to buy a camera, you would look at the specification of the camera, you'd have some idea what you wanted the camera to do, and then you go into the marketplace and choose the item you wanted. You would have a very good understanding of its utility because it's easily measured, its usefulness and its purpose. Then you have a second category of purchases, which are described as experience goods. Staying in a hotel, going to watch a film, perhaps enjoying a glass of wine. And these, in this case, before you attend the event or experience this, you have some idea as to what you're expecting, but you don't really know the utility until after you've experienced it. You need to get to the end of the film to make a judgment as to whether you enjoyed it, whether in the way it was filmed or directed, or the script, what you thought of these things. So those are less easy to measure, and to a large extent, they're also personal. The third category are known as credence goods, and this is where healthcare fits in. So in a credence good, when a person purchases a credence good, from credo, the Latin word to believe, when an individual purchases a credence good, they often have no idea of its utility. So to put it into a very simple example, patient comes to see you, you diagnose some occlusal caries on a lower left 6, which you feel needs some intervention, and you provide a minimally invasive composite resin restoration. When the patient came to you, they had no pain. When the patient leaves, hopefully they will have no pain. The patient doesn't really know what the value of the intervention is, because they are not in a position to actually measure it. And it's other services like legal services and so forth are largely based on trust. And this difference in the knowledge between the patient and the dentist, broadly speaking, is often described. Forgive me, my computer seems to have frozen here. This information gap is often described as information asymmetry. So when we say what is the business of dentistry, this is the conclusion I would draw. So let's just imagine for a moment that we're all in a room and I present a patient to you and I ask you to have a look at the lower right 6. And I say to you, this lower right 6 has received a crown. And I would like you to look at this crown and judge it for its quality. As clinicians, we would all do the same thing. We would look at the margins, the accuracy of the marginal fit, the emergence profile, the embrasure spaces, the occlusion, and so on. And if everything was absolutely perfect, we might give it 9 out of 10. I remember one of my dental school tutors used to always encourage us to mark our own work, and with the proviso that you never score 10 out of 10 because only nature gets 10. And his exact words were, it would be an act of supreme arrogance to consider that anything you had done was as good as nature. So we make all these assessments and we conclude that the patient's crown, the quality of the crown, is worthy of a 9 out of 10 score. That's an important assessment, but ladies and gentlemen, it's not the most important assessment. The most important question to ask is this: was the provision of the crown in the first place the correct clinical intervention and the most appropriate clinical intervention according to evidence-based dentistry? Because if it was not, then actually it doesn't matter how good the crown is, because it should not have been provided. It can be argued it should not have been provided. So the relationship, actually, the business of dentistry, the conclusion here is the business of dentistry is actually the business of trust. And I know Alistair will pick up on this a little bit later. And the reason why I want to bring this in at the outset of my presentation today is to highlight the fact that everything we do, everything we say to the patient, all the warnings and the advice and the benefits we discuss are all witnessed by others in the room. Your dental nurse, possibly more than one dental nurse if you're working with a nurse. If the patient is coming back 3 times and you've got 3 different nurses, and your staff and your team are constantly, consciously or subconsciously, assessing your behavior as the leader of the team. And we'll come back to that theme a little bit later. I'm just going to invite you for a moment. I've made quite a bold statement, so I just want to back it up with some research, a fabulous paper, one that I've quoted so many times, published in the Journal of Economic Literature some years back. And I'll just invite you to read the quotes. And these are verbatim quotes. I've not changed anything to make it fit the presentation. And this talks about, we just need to change the word consumer to the word patient, and it completely highlights what the challenges are in terms of trust in what is essentially a credence goods market. And the trust equation can be summed up with what you see on the screen. It's credibility, reliability, and intimacy, and the denominator is the self-orientation. In any interaction, whether it's with your team or with your patients, if the receiver of that communication gets a sense that your decisions or your actions are being driven by this denominator, it undermines trust. And it's a very, very powerful equation, and it can be applied in so many ways. I would quote Stephen Covey's book to you. There are some books that I will read, and I will, to be honest, skim read them. I will read them very quickly, and perhaps I'll probably miss some of the detail. But time is short. We're all very busy. We don't have the time to go through everything cover by cover. And then there's a handful of books which, when I've read them, the reading has been so pleasurable that I've slowed down the pace. I've not wanted the experience of reading to finish. And this is one amongst maybe half a dozen. It's a wonderful book and beautifully written. And Covey stresses the first job of a leader is to inspire trust. And by behaving in ways that build trust with one, you build trust with many. And this goes back to my point about working in a clinical setting with your nurse by your side. If the nurse is witnessing ethical, evidence-based, patient-centered procedures, the nurse will talk about that to your colleagues in the practice, to other team members. And in my experience, in my own practice, we had 6 or 7 dentists working there. Many patients would ask reception, new patients would come in and they'd say, well, I've been recommended to so-and-so, but I know that that person's list is full. Who is it that you think I should see? And then the reception team would have to make some sort of judgment. And if it was a good friend who was visiting and wanted to register with our practice, the reception would say, well, actually, if I was you, I would see person X, and this is why I would see them. And quite often, the reason given was centered on this concept of trust. And people will trust you when they believe that what they see is the real you. And this is this concept of authentic leadership. Last week was Diwali. I'm Hindu, so we celebrate Diwali, and for the first time in my life, I've made some Indian desserts. And they should have taken an hour and a half. They actually took 4, but I got there in the end. And on Diwali, this is a picture of our Chancellor. This is Rishi Sunak. And on Diwali, the Royal Mint had released a coin, a £5 coin, not for general circulation, kind of a collector's item. And Rishi Sunak is shown here holding it. And it was to commemorate the contribution of Mahatma Gandhi over so many years, and to pay tribute to what Mahatma Gandhi had done for the Indian people. And it reminded me of a story which I'll include in this presentation, which I think is relevant to what we're covering today. So pictured here on the right-hand side is Mahatma Gandhi, and on his left is a gentleman called Mr. Desai. Now, Mr. Desai, excuse me, Mr. Desai was Gandhi's personal secretary for many, many years. And his first name, I think, is Mahadev Desai. And in early 1930s, Gandhi had arrived in Britain to attend a roundtable conference. And it was also attended by a number of members of parliament. And, he appeared frail. He was dressed in simple clothes. He held no political office and had, little wealth. And he spoke for almost 2 hours without any reference to any notes, mesmerizing many members of parliament that were sitting there listening to him speak. At the end of the event, it was very difficult for the press team that were there, for members of the press that were there to reach Gandhi because of the crowds and the security and so forth. So one of the press people approached his secretary, Mahadev Desai, on the left, and he asked him some questions. And one of the questions he asked him was, Mr. Desai, we've just witnessed Mr. Gandhi speaking for 2 hours faultlessly with no notes. Can you tell us how he can stand up and address the assembled audience for 2 hours with no hesitation and with no notes? And ladies and gentlemen, I will share his reply with you, which for me sums up the concept of authentic leadership. And that's the key, ladies and gentlemen. That, to me, is the definition of authenticity. And if you are able to communicate authenticity to your team and your patients, then that is a massive driver for the growth of your business. And I know it's a theme that's going to be covered later in your conference today. In terms of growing the business and the role of leadership in growing the business, just a couple of slides to for this, and just to reference them, and because I would hope that you would then go on perhaps to investigate this principle a little bit more. And this is the concept of the service profit chain, written by Messrs. Heskett, Sasser, and Schlesinger, who are pictured on the left-hand side. And the concept of the service profit chain is very simple. The image you see on the right is taken from a paper they published in the Harvard Business Review. It was very well received, and then the book came later, I believe. And you will see one of the key links in the chain is internal leadership. And the concept of the service profit chain is simply this: your profitability is only as good as the weakest link in the chain. And again, talking from personal experience, this has probably been the most influential non-dental textbook in my clinical experience and in my experience of running a practice. It's not a recent text, but I think it applies as much today as it did at the time that it was written. Service Profit Chain, a sister book, a companion book, if you like, is called The Value Profit Chain, and I would highly recommend that too. I just also want to cover off this notion of ethical competence. It's a phrase that we don't often hear, but it's very easy to say, be an ethical leader, but actually, what do we mean by being an ethical leader? What we really mean is that, we all must have an element of ethical competence. And ethical competence is made up of two elements. There's what's called ethical capacity. This is the theoretical knowledge and understanding of the principles of bioethics, the principles that were first sort of set out by Beauchamp and Childress in their book, Principles of Biomedical Ethics. That book, I think now is in its 8th or 9th edition. It was originally written 40 years ago, a very valuable book. Some limitations, some commentators have said there are some limitations to applying those principles in the modern world, but overall as a foundation, it stacks up pretty well. So it's about understanding the principles and understanding the ethical healthcare principles, but also having an understanding of some kind of some philosophical principles as well. And then the second element is being able to apply those through a process of moral reasoning and being able to solve the practical ethical dilemmas. And that is always where the gap is. Ladies and gentlemen, generally speaking, people have a very good knowledge and understanding of many things. The gap, in my experience at least, is always between the knowing and the doing. Yeah, the gap is between the knowing and the doing. So two elements to ethical leadership. In terms of the broader ethical considerations, and this is taken from a July 14 issue of the paper that's quoted there, published in Harvard Business Review, reproduced here, with permission and full acknowledgement. And you will see that when it comes to the competencies, you will see that integrity and honesty stacks up pretty high. Yeah, it stacks up pretty high. So again, just some evidence that I'm presenting here to support the principle that I've just presented. A more focused argument written by Dr. Grasskempner in the Journal of the American Dental Association back in 2002. And again, if I may just invite you, please, to read this quote. So given that the work that Alistair and I do, given that the work that MPS and Dental Protection do, I thought this was a very relevant quote to include in my presentation today, because the other benefit of trusting relationships with patients and team members is that actually it's a very, very effective risk management strategy. Patients will be very forgiving and they will be very tolerant of human error, provided they perceive you as a trustworthy individual. I would always say that the patients need to buy into you first as a person before they buy into you as a dentist. And that was always my experience during clinical practice. So a few personal reflections, and then I will hand over to Alistair. So these are just kind of my own views, if you like. There is some support in the literature of them. But if someone were to say to me just in 2 minutes, give me a summary of what kind of worked for you in practice and what didn't. I'm no longer a practice owner, but I still do occasional clinical sessions in the practice where I worked, because some of those patients I've known for, 30 years now. And to be honest, it's a joy to look after them. It's a privilege to carry on looking after them. So personal reflections, great believer in authenticity. And we've covered that already. We've mentioned it in my introduction, mentioned it in the context of Mahatma Gandhi's visit in 1931. Just a definition as to what it actually means. And just a slide, if you focus on the center of the slide, you'll see 4 quadrants, S1, S2, S3, and S4. This is about leadership of the internal team. And what I'm trying to say with this slide is that when you've been in the same practice for a long time and you have team members that have joined you, in our case, sometimes straight from school and still been there 15, 20 years later, we have a duty as a leader to also develop the team. And the relationship with a new team member might be as described in S1, where there's more directive behavior. You know, I would like you to do this. This is how I would like you to do it. And the team member is coming back to you constantly for advice. And that same person then stays with you for a while, they develop, and then you can end up at the other end of the spectrum where you say, oh, you're doing this so well, I don't need to do this function anymore. I'm going to delegate it to you. And I think that's another responsibility in leadership that's sometimes forgotten. And presented with a slightly different graphic, that's pretty much what it looks like. Yeah, the use of authority and direction by a leader with the same team should get less and less, and we should give autonomy and more freedom to team members. You know, autonomy is one of the 3 features that makes work satisfying. You know, the other 2 being a connection between effort and reward, and the sense that we are contributing to something for the greater good, which in healthcare we always are. So my last slide, a quote from the Institute of Business Ethics, and I think it says it all. It's the core word in any definition, in my view, when it comes to healthcare. And I know Alistair has worked hard on his presentation to pick up this theme. So I will now thank you for your attention and hand over to my friend and colleague, Alistair McKelvey. Thank you, Alistair.
Thanks, Raj. For your Man United supporters, the news is getting even worse. The score is now 2-0. So let's get back to talking about leadership. Raj, can you move this on? That's great. Now, I just wanted to share this quote with you from Professor Warren Bennis about leadership. For me, it summarizes what leadership is all about, and good leaders find a way of doing the right thing or know what the right thing is to do. So it's a blend of personal skills, humility, emotional intelligence, knowledge, technical skills, and risk management awareness. If we move to the next slide, just the one back from that, Raj. Yeah, now I've actually rewritten this quote. I could have put Professor Alistair McKelvey there to go with Warren Bennis, but I put Doctor. And you know, this has relevance to leadership in a dental practice. The leader in the dental practice is generally the owner. They may be a dentist, a therapist, a hygienist, maybe a single-handed practice or a bigger team. But what good leaders have in common is that they do what they say and they say what they do. And that just refers back to Gandhi. So these leaders are trustworthy and they act with integrity. They get involved in daily work where it's needed. They stay in touch with what's happening throughout the practice. Great leaders don't just sit in their offices and give orders. They just continually demonstrate the actions and values that they expect from the team. So next slide, please, Raj. Raj is probably away watching the football. Raj, can you maybe move to...
No, I'm sorry, Alistair. I'm trying hard to work out what's happened here because that's it.
Great, wonderful. So in this section, I'm going to talk about what good leadership looks like in these 3 specific and important domains. So we're going to look at leadership with complaints, complaints handling, leadership as it relates to record keeping, and leadership when it comes to consent and managing difficult conversations. So let's move to the next slide, please, Raj.
I seem to be having some difficulty with the advance button on the laptop. Let me...
There we go. So what is it that patients complain about? Well, there's lots of different reasons why patients complain, and I've put just a few of them on the slide here. These are a few of the things that happened to me when I was a practice owner, and some of them are quite funny when they happen, and some of them just need to be taken more seriously. I had to deal with some of these issues myself And specifically because we had 2 oral hygienists working in the practice, and one was slightly better clinically, technically, but the other one was a much better communicator. Karen was the technical one. Kath wasn't quite so good at cleaning teeth and root surfaces, but the patients loved her. So for some patients, I just had to make sure that the ones who liked the soft skills were booked in with Kath, and the ones that were more prepared for a thorough treatment session went to Karen. And we had to create a strategy. We had to recognize that there was potential for people to make complaints if they were booked in with the wrong hygienist. And when I go to the hygienist, all I want is my teeth properly cleaned. But many of our patients use a different proxy than just the thoroughness of the treatment to evaluate the quality of the service. And it's understanding how patients evaluate quality that helps us cope with the emotional fallout of a complaint. Next slide, please.
I seem to be having a technical difficulty here with advancing the slides. May I just suggest I'm going to stop sharing and reload the presentation? I appreciate that interrupts you, Alistair, but it might take care of the problem.
That's fine, absolutely, no problem at all, Raj.
Thank you.
While Raj is fixing the slides, what I want to talk about is, that's it. How do you know when patients are unhappy? Well, from our experience, the majority of complaints are made after the event once the patient has got out of the dental chair. It's not a good idea to complain while you're having a tooth removed or you've got a rubber dam over your mouth. But there are occasions when a few patients will stop you and tell you it's uncomfortable, or they're drowning with water, or they don't like the taste of something. And it's really important that you acknowledge that they are unhappy and find a way of resolving that problem, even if it means actually ending the treatment session earlier than you would have done, and getting the patient to come back in maybe on another day when they're less distressed. So after the event, complaints are commonly seen on the way out of the practice. And you get comments like, I'm not seeing her again, or can you book me in with Kath next time because Karen really hurt me and made my gums bleed. And occasionally you'll have people that just want to tell the whole waiting room that there's an incompetent dentist in there and you shouldn't be going anywhere near them. And then you get the complaints in writing, and most decent people would give negative feedback in a constructive and private way via a letter, an email, or even just a phone call. But the line of least resistance today, with the potential for widespread reputational damage, now seems to be on social media, specifically Google reviews. And those comments can be personal, they can be designed to hurt, and even verging on defamatory. And sometimes the complaint is not even made by the patient and can be made by another dentist. So next slide, please.
I'm having the same issues actually. That's it.
There we go. So what is it that makes some patients more likely to be the type of person to complain? Well, we can spot them a mile off, and there's some people that are just never happy with anything. And unfortunately, it's part of our job as dentists. You're just never going to please everybody. But, you know, if I asked you to write a list of the 10 people you least like to see, you'd come up with the names, you'd come up with the same names all the time. And those are the people that sap your energy, that drain your energy and get everybody an edge. And they're the ones that are generally unhappy, no matter how well you treat them. But what we are seeing is we're seeing an increase in the number of complaints about fees and excessive fees, and a lot of it has to do with the hardship of COVID, and we understand that. But quite often those complaints about fees are related to a lack of information, and we'll probably talk about that in a minute or two. And the final bullet point suggests an aggregate of negative experiences over a period of time at a practice can be a driver of complaints. And I'm going to look at this in a little bit more detail in this slide. So there's been a fair amount of research around complaints, and the work of Bunting looked at the relationship between precipitating and predisposing factors as a driver for complaints and litigation. So let's be clear, a precipitating factor is the material event that happened on treatment day. It can be a painful pulp extirpation, or a crown that keeps coming off, or, as I mentioned just there, an unexpected co-payment. It can be other more serious issues like a failure to diagnose a chronic or aggressive periodontal condition and provide appropriate management for treating to that. And then the patient loses some teeth and it wasn't the outcome they were expecting, and they're now faced with paying for an expensive implant replacement. So a predisposing factor or factors are the negative things that the patient has noticed or experienced when coming for treatment. So these are the things that wind people up, annoy patients, and we're going to talk about them in a second. In dentistry, there are, of course, problems that are inevitable in a small percentage of treatments. Dentistry, like any other field of healthcare, cannot give absolute guarantees of success on each and every occasion. Something sometime will go wrong, no matter how much care is taken or how talented the treating team is. Can we go back a slide or two, Raj? Yes, thank you. So the precipitating factors are the immediate precipitating events, but the decision to complain or litigate is often made much early in the relationship, and it's got a lot to do about predisposing factors. Now, a predisposing factor, as I mentioned, are the things that wind patients up. It's things like somebody being rude. They turn up for an appointment that should have been cancelled because the dentist was sick or took a holiday or went to play an important golf match. Other things like patient turns up for an appointment and being told they can't be seen as they've come on the wrong day. Another predisposing factor is poor timekeeping. We all run late occasionally, but if we are consistently late and keep patients waiting, then it can easily cause irritation if it's not managed correctly. So the research suggests that the greater the exposure is of a patient to predisposing factors, the more likely they are to complain when a precipitating factor happens. So if you want to work on reducing the number of complaints that you receive in your practice, the important thing to do is to make sure your staff understand that it's more about predisposing factors, the rudeness, the delays, the lack of communication, those things that wind patients up, they store them in their mind, and then when they have a precipitating factor, then that is where they will complain. A precipitating factor, a painful pulp extirpation without any exposure to predisposing factors, is less likely to lead to a complaint. So if we can move to the next slide, Raj. Thank you. So when we receive a complaint, what are we supposed to do? Well, do we just bury our head in the sand and hope that it goes away? Well, some people do. But we do have an ethical obligation to respond to complaints, and it's hidden away at section 5.1.10 of Booklet 1 of the HPCSA ethical guidelines for good practice in healthcare professions. Now in there, it says you should respond to criticism and complaints promptly and constructively. It doesn't say you must, but our experience of assisting healthcare practitioners who ignore complaints is that things can easily get out of hand. And if the patient's left feeling that their grievance is being ignored, they will generally take the line of least resistance, and it costs nothing more than 15 minutes of their time on the internet to lodge a complaint with the HPCSA. So if we go to the next slide, Raj. Just one back. Thank you. So what does a good leader do to reduce the potential damage that an unhappy patient can cause your practice? So the good leader will recognize that actually complaints are a good thing to happen to the practice, and they provide an opportunity for service review, service recover, and they will make sure that patients know if they have a concern, that concern will be heard and the correct action taken. Responding to complaints professionally shows you care about your patients and that their disappointment really matters to you. A good leader will also make sure the team understand that complaints are not something to fear. And a good leader will make sure that the staff have the skills and they know how to manage complaints effectively, whether that complaint is made verbally or in writing. And finally, a good leader will make sure that the team work really hard on reducing or eliminating those predisposing factors, because it is those things that drive complaints more than a poor clinical outcome. So next slide, please, Raj. Thank you. So if we accept that good leaders do the right thing, then they also set the standard for record keeping within the dental practice. Next slide, please. Healthcare professionals are expected to behave in a way which commands public confidence, and they do this by displaying all of the characteristics listed in this slide. One of the characteristics of professional groups is that they are expected to have the dedication and commitment to meet a set of standards that their peers find acceptable. So this is the professional standard. One of these standards includes making and keeping good records. Next slide, please. If we accept that making and keeping records is a standard all professionals are expected to meet, then poor record keeping may be considered as unprofessional. In other professional disciplines, record keeping drives trust, whether it's in the banking sector, the legal sector, the aviation sector. Records, memory, and accuracy of recall through recording breeds trust between the service user and the service provider, and our profession is no different. So professionalism is fundamental to the business of record keeping. Next slide, please. The professional obligation to make and keep a record can be found in the HPCSA guidance and good practice. And it is against this guidance that your conduct is measured when the HPCSA conduct an investigation into your fitness to practice following a complaint. The absence of an accurate and up-to-date record will be considered as unprofessional conduct by the HPCSA disciplinary committee. So you have an ethical and professional obligation to make and keep a record. Next slide, please. There is also a legal obligation to keep good records. And we look at what the National Health Act says, and this is specifically aimed at the person in charge of a health establishment. This is the practice owner. And the National Health Act at section 13 places a legal duty on the leader in the practice, the owner of the practice, to make and keep a record. And therefore, because it is a statutory duty, a failure to create a record for a patient could actually be considered an offence. So next slide, please. So let's look at some data. How good are dentists doing in South Africa when it comes to record keeping? Well, unfortunately, it's a bit like Manchester United's performance today. They're not covering themselves in glory. And what we did at Dental Protection is we had a look at all of the records we were given by dentists in South Africa who were being sued in 2017. And we need to see the records so that we can see whether we can defend the dentist against the allegation. But the data is quite worrying, because if I ask you to list the key information that should be recorded for every course of treatment, all taught to you as undergrads, you would have listed these data fields as being the most important. Yet if we look at the outcome of our audit, we can see that only 4% of records had any information about what was discussed. No information about what was discussed with the patient. Only 1/3 of the records had a medical history, and less than 1/5 had an up-to-date charting, and that's all basic undergraduate stuff. If it wasn't written down, it didn't happen, is what's usually said about poor record keeping. It can be a bit of a myth, because the law in South Africa, for example, doesn't you to write down what was discussed in the consent process. It just requires you to have a conversation with the patient. But if that patient says they weren't informed of a risk and what that risk would mean if it materialized, and they would have chosen a different treatment avoiding the injury they're now suing you for, then it becomes a problem for you if it's not written down. And just because you are a professional doesn't necessarily mean the courts will always prefer your version of what happened to the patients. So the key here is that we all have a legal and ethical obligation to make a record. The record's part of the treatment, consent is part of the treatment, and making the record cannot be separated from the treatment. Good effective record keeping is a marker or a proxy for professionalism and good care. And the absence of good records is unprofessional, unhelpful, and unethical. Next slide, please. So what are we trying to achieve with our record keeping? Well, I've created a summary definition here of what we're trying to achieve. And if your dental records can fulfill these requirements, you will be meeting the legal and professional standards expected of you. So a good record will be clear, it'll be accurate, it'll have enough information in it so that when I look at it, or Raj looks at it, or the HPCSA look at it, they will be clear to the actions you carried out, as well as the thinking and the logical analysis and the judgment applied to the diagnosis and treatment, and they will know what information was given to the patient. So there's a record here, and this is a really good example of a record that confirms, thank you, Raj, treatment carried out. And you can see on this record over 3 appointments that 2 teeth were extracted. Tooth 27 was extracted at the first visit at the top line, and then the second line below, tooth 28 was extracted. Now, the story not told by the record is that the patient came with pain and pointed to tooth 27. The dentist had no X-ray facilities and took the patient's word that 27 was the problem. The dentist said that he could see decay, he could see it through the enamel, but there wasn't a cavity in the tooth. So he took the tooth out, and lo and behold, the patient came back a week later saying the pain was still there. So he pulled tooth 28 out, which he said was intact, but was just a little bit mobile, as it might be a week after extracting the tooth in front. And you can see in the entry at 16th of October, he didn't even charge the patient for the extraction. So then what happens next? Patient contacts the practice again, saying the same pain is still there, and accuses the dentist of pulling 2 perfectly healthy teeth. So how do we defend this dentist? Well, occasionally we'll all pull the wrong tooth, but if we can show that the error was a mistake and not negligence, then we can defend the dentist. But the problem with this record is that we just can't justify either extraction. And what we really needed to see here in this record was, number 1, a pain history, 2, evidence that vitality tests were carried out, 3, a diagnosis. What was it that was causing the pain and where was it? 4, what options for treatment were available for that patient? And 5, the patient accepting the risk of not having X-rays or delaying the treatment until an X-ray can be taken. And it's not a lot of additional information. It's the sort of stuff we almost do in automatic pilot. But if it's written in the record, then we've half a chance of defending the removal of 27, but definitely not 28. The removal of this tooth should never have happened. And you'll also notice at the top, there's no charting for this patient, but code 8101 was claimed. And if we look at the narrative for 8101 in the SADA codes in the next slide, we can see that record keeping is part of the examination, and that part of the fee claimed pays for you to write up a proper record. So 8101 says the procedure description is the findings of the full mouth examination, including a complete dental charting and treatment plan, must be recorded accurately and legibly on the patient's record card. This is essential for defending dental legal cases. Well, yes, of course, it's essential for defending dental legal cases, but it's actually more important for good patient care. And leaders recognize that good record keeping is a non-negotiable in a practice that aspires to be the best. Next slide, please. Now, then we have this case where we can see again that the dentist charged the patient for an 8101 examination. But again, you'll notice at the top, there is no chart of the patient's teeth. So at the appointment I've arrowed there, the patient had 2 fillings done on 2 lower teeth, 3.6 and 3.7. And tragically, 2 days after this appointment, the patient was involved in a tragic car accident and she was burnt to death. And the only way to make a positive identity was to match her teeth with the dental chart. So the forensic pathologist asked the family who was the dentist and could they get hold of the dental records. And of course, when they did get this information, that is all that they had. Now, the dead lady left a loving husband, 2 young sons, and they were beside themselves with grief. Because there was no charting, even though it was an absolute requirement of 8101, the forensic pathologist could not identify the body and therefore had to rely on DNA testing, which took months. The pathologist reported the dentist to the HPCSA for fraud, for claiming for 8101 when he hadn't in fact fulfilled his record-keeping obligations. This family had been caused immeasurable suffering and distress because they were unable to lay their loved one to rest. The HPCSA investigated the matter and charged the dentist with unprofessional conduct for claiming 8101 without having a dental chart. We move to the next slide. You will see that this was the charge, and there was a significant admission of guilt fine that the dentist had to pay. Now, I can accept this is a very, very rare occurrence. Probably might not even happen once in a professional career, but it demonstrates at a human level the consequences of failing to write a proper record. So a good leader will set their standard of record keeping by making sure he or she records all the information that is expected. And by doing that, will set a standard that the whole team will see and respect and integrate into their own record keeping. For me, good record keeping is just a non-negotiable. But as we often see, it falls short of the standard required, and that has consequences. So if we look at my final slide here on record keeping, it summarizes what a leader will do and how he will justify the standard for his team to follow. So the leader will recognize that you've got ethical and legal duties that you have to comply with. The leader will set the standard in the practice and expect everybody else to follow it, because he understands that this will protect your patients, it will protect yourselves, and it will help your indemnifier as well when things go wrong. Next slide, please. So in this final section, I'm going to touch on consent, but specifically on making you all aware that a consent, a valid consent, can be invalidated if the cost of the treatment is left out of the discussion. And if we move to the next slide, I'm going to tell you that almost 1/3 of the complaints made to the SADA mediator or to the HPCSA contain, amongst other allegations that the patient was not made aware of the costs of treatment. And a lack of information about costs will invalidate the consent process, particularly where the patient can demonstrate that the lack of information restricted their choice of treatment. So the patient might say, well, had I known it was going to be this expensive, I would have opted for a much cheaper option like an extraction. And there are 3 different statutory pieces of legislation, acts, that create this legal obligation to inform a patient of costs. At the top of the slide, we've got the National Health Act, which says the user must be informed of the benefits, risks, and costs associated with each treatment option. The Consumer Protection Act, which a lot of people don't think applies to dentistry, does, because you're supplying goods and services, and the supplier must disclose the price of goods or services. And then, unfortunately, we have an ethical obligation. The HPCSA Ethical Rule 37A is that says the dentist shall provide adequate information about the costs of treatment. The only thing I would say at the bottom is that the Health Professions Act seems to be a bit out of step with the first 3 obligations. And this is a bit dated legislation and probably needs to be amended and bring it in line, because you cannot rely on giving patients information about costs if and only when they ask for information. And also this idea about informing the patient of the cost of treatment when such a fee exceeds that usually charged, that relates to when there was a tariff of fees, and that's no longer available either. So if we move to the next slide, if we know that a lack of information about fees drives complaints, we also need to make sure that we can manage those complaints effectively. If we do that well, we will hang on to our patients. And in many cases, some of these patients become loyal ambassadors for our practice. So if our staff know how to handle complaints and have had proper training, they will feel more able and engaged to discuss concerns with the patient and confident, rather than being afraid and becoming defensive when someone's unhappy in your practice. Next slide, please. So if we accept that complaints are inevitable, a good leader will make sure that the patients know that they can complain when they're unhappy, and that the staff are properly trained and equipped to handle those complaints professionally and effectively. So a leader will make sure that patients understand if they're unhappy, they can feed that information back to the practice rather than take it away home with them. A good leader will make sure that his staff are supported and trained to deal with effective complaints management. A good leader will recognize that sometimes it's not easy to accept complaints, and people don't like personal criticism. And they don't like being accused of not advising about cost of treatment. A good leader will make sure everybody knows how to investigate a complaint, not necessarily find out whose fault it is, but find out where the failing happened. And a good leader will show that he values the views of a patient and understands the views of a patient when they're unhappy with service. And if we move to the next slide, I just want to give you a little bit of help here about a way we think will make those difficult discussions with patients easier. And we recommend the AID model, and it's pretty simple. And the conversation you have with an unhappy patient is structured to follow the acronym. And if we click to the next slide, we'll see how this all works in practice. So A stands for acknowledge the patient's position. And acknowledging the patient's position means actively listening to what they're unhappy about, not interrupting, giving them the opportunity to tell their story. And then what you do, once you've listened to their story, you summarize their position and their feelings and make sure that you've actually understood this correctly. So I'm the patient, I'm unhappy. Raj is the dentist, so he'd be saying to me using the AID model, so Alistair, you're unhappy that your medical aid hasn't paid your account in full, and we're obviously not expecting this additional account. You say you should have been warned about this and are a bit irritated, is that right? So That's what you do when you listen and acknowledge the patient's position. Let's move to the next slide. I stands for inform. So this is the point in the conversation when you tell them about your position. This is where you say, as I explained, when the claim was submitted, your funds were depleted. This was not the case when we contacted your medical aid before the treatment began. This cannot be my fault, and we have a problem here. So what you're saying is you understand that this all came as a bit of a surprise to the patient, but there is actually a reason why nothing has gone wrong, and there's a very simple explanation that the patient hadn't considered. And then we move on to D, which is on the next slide. Once you've understood the patient's position, once you've presented your position, it is now the time to discuss a way forward. And you do this by finding solutions. I'd like to know how you think we can resolve this problem, Alistair. You are responsible for paying your account. So you're asking the patient to suggest possible options, and you try and find some mutually acceptable compromise or reasonable grounds that is an acceptable solution for both parties. And this process can be shared by your team. This is something that you don't necessarily have to get involved with, but as a leader, this is the skills that you need to demonstrate. These are the skills that you need to take to train your staff to do, and the AID model is just so simple and everybody can manage it. So let's finally finish off with a couple of slides here. So now we know how to run the conversation. Let's focus on what we can do to reduce the need for that conversation. So remember, you're required to provide a costed treatment plan. It's important that each patient knows what the practice will do if there is a shortfall in the payment recovered from the medical aid. That means that the patient knows if the payment's not there from the medical aid, that they will be responsible for a co-payment and paying it. But it's equally important that your patients know this before the treatment is started. That's when the fee discussion needs to happen, not afterwards. If it happens before, it's an explanation that's part of the consent process. When it happens after, it's probably too late and it is an excuse. Now, if we move to the final slide. So what I'm going to suggest to you as a kind of take home here is that this simple statement is included in your discussion about treatment fees. So what's highlighted in red is something that you need to make sure you have this conversation with your patient. And that's what it said. This payment, which you are responsible for, may only become apparent after the claim has been submitted. And being a member of medical aid and getting pre-authorization does not always guarantee payment by the medical aid. And if that happens, you are responsible for setting the treatment fees in full. So you're telling the patient about the estimated cost of their treatment, and then you're saying to them, if something happens with the payment and we get less than we're expected, it's not our fault, but it's your responsibility to pay the co-payment yourself. If the patient understands that before and something happens afterwards, then you're in much safer ground. It's all about leadership, and it's all about making sure that everybody buys into reducing the risk of complaints about fees. Fees are not easy things to talk to patients about. We're all worried if we quote a patient too much money, they'll refuse the treatment and go somewhere else. But I guarantee you, if 35% of the complaints are about fees, once you talk about fees and get comfortable talking about fees, just think how many difficult conversations are not going to be there in your practice. And this, ladies and gentlemen, brings me to the end of our presentation. And if you want to have a look at our website, then there it is. It's a fairly simple website to join. We have a page on our website dedicated to our South African members. And as I mentioned, if you need any more information about dental protection and you're at Congress today, then please go and say hello to Zodwa at the back. I can't see Zodwa because I've not got a view of the audience, but I know she's there. So thank you very much for spending the last 45 minutes with Raj and I. And I don't know if there are any questions, Raj, but if there are, maybe we can pick them up.
Alistair, thank you very much indeed. And thank you also for so skillfully accommodating and navigating the hiccups with a slide, because it did feel a bit like a hiccup, didn't it, at the beginning? So I'm glad we were able to resolve that in the background. So thank you for your presentation. We're both very happy to take any questions if there are any.
I don't see any, Raj, in the
no, I don't see any
function. And I'm waiting for our good friend Venus to let us know if we can leave the stream or not. But all that remains is for me to wish you the end of a very successful Congress. Raj and I have been regular visitors to South Africa, and we'd love to have been there with you. We might not have had the technical glitches if we'd been there with you, but hopefully things are looking up for 2022. And we'll be back in country and looking forward to seeing as many of you as possible. So if there are no questions, Raj, it's a Saturday afternoon and I'm going to go and do something else now.
Thank you, Alistair. And can I just also, as a final comment, just say thanks to Venus and all the team in the background. The preparation of this has been as thorough as you can imagine. We were able to connect effortlessly today. And even in the run-up to this event, we've had 2 or 3 opportunities to confirm some sort of processes and so forth. So that my thanks, and I'm sure Alistair feels the same, our thanks to all of you for making it so simple and straightforward for us. Thank you.
I have a few questions. I'm also asking who is new technique. The first one, I just want to understand the position of gems. If you, as a dental practitioner, would pay a practitioner to move in team at different prices, is it fair? For example, 8.21 also 8201 and 8202. They are different fees, but they are the same procedure. How can the medical aid says it's fine to pay is 100 rand to the first one and 50 rand to the second one. That's just one example of many. You can go to the canals. If I do endo, and now you know MB2 is getting common. So I thought I was lagging. MB2 is getting common. We are getting 6 canals in one tooth. And you claim, then to come back say, no. You only can claim up to 4 canals. While you as the practitioner, you saw with your microscope that you cannot even claim from medical aid. And now the patient is coming with serious infection and you opt to use NTA as a sealer. The very same medical aid doesn't pay NTA. To Dr. Siping's comment on patients have been waiting for medical aid. And Dr. Maluleke also mentioned that we are taking patients' money, not the medical aid's money. So if we claim, why can't we get paid as per the way we are claiming, the way we did the work, not as per the medical aid's discretion? Because if the patient comes to me and I assist the patient, I believe both parties, they did their part. There was no any fraud committed there. So I believe everyone should have. Let me just go to the second last important one. But rather than I received a letter. I don't know whether was it directed to me or it was just a general letter where they said I shouldn't claim rubber dam because rubber dam is included in 8110. 8109, yeah, 8109. The code 8304, it is part of 8309. I don't know when did that happen. Let me just pause there.
They said it's part of PPE. It was part of PPE.
Who asked the question?
Okay, I think you know what, when you start talking about with medical aid, we won't finish, right? So, and I wish to apologize that we are running out of time. We are an hour or so late, so can we maybe arrange that Dr. Maluleke come back at a later stage? Just him, one full day, right? Then we'll talk about all the tips issues. Please, guys. We are running out of time. People who are not here, they are joining from elsewhere. You know, we are just being unfair on the people who are not here. All right? So we put that aside. I know it's important, guys, right? But we don't have time today. Guys, we have to finish. Pardon? I'm sorry, but rather we have to finish. So, please finish. Sorry. The agreement is, sorry, colleagues, the agreement is Dr. Maluleke self-available, but is going to, all the answers is going to jot them down, send them back to DPA, and then we'll have them in our chat group. The question and the answer. Please, for the benefit of those who are joining us regularly, so that we can assist them as well.
Right. Without a waste of time, colleagues, I'm going to call the next speaker or the presenter. Dr. Dudu Ntambo. Dr. Dudu Ntambo. Where is Dr. Dudu? Come closer, Dr. Dudu. Yeah, come introduce. Come introduce.
Quickly, it's the normal one.
Oh, credit stuff okay, right? Let's screen that. It didn't benefit us because most likely to be a guy. So it's no signal. So ordinarily there's no end. It's a tumble like that. Yeah. Oh. This just check it in.
Do I need to unzip? Make it feature the needs more. Is it on? How will I know it's on?
Good evening, colleagues. We are almost reaching the end of our conference. This is our second last speaker. Her name is Dr. Dudu Tambo. She obtained her degree. Yes, also still at UT, University of Victoria. Her savvy business acumen has been elevated by a post-MBA and MPA qualification that she obtained from Marcosa. She will be presenting the topic of dentistry. Dentistry is a big business.
Yeah,
This is for the study.
Right, good afternoon, colleagues. Thank you so much, Doc, for that lovely introduction. Like Doctor has said, my name is Dudu Tambo. I feel like, maybe there should have been a little, ad that comes with the publication of the advertising of the conference that says, maybe I'm because looking around, I'm seeing a lot of I admire. So I feel like a kid. But anyway, thank you so much for such a field statement. When I was given this topic, there were a lot of ideas that were going through my head. And I was wondering, okay, dentistry is the big business. Where do I start? Because big business, dentistry, really? But let's talk. Why do we say that dentistry is a big business? In its nature, dentistry is an entrepreneurial industry. What do I mean by this? If you are a dentist in private practice, you have to be disciplined. You need to have consistency. You must be passionate about what you do. Because if you don't have passion and you're not motivated, when the days are really, really dark, you're gonna want to pack your bags and give up. So when you think about entrepreneurship, it is a very lonely journey, understand? So you really, really need to have that drive. You need to have that push that says, you know what, keep going. You have to be innovative and creative. Be willing to take risks. Because if you do not take risks, there won't be any growth. So why do we make such great entrepreneurs? I mean, we dentists, we're just dentists, right? So why is it that I say we make great entrepreneurs? I don't think there is anyone in here who can say they don't have one, if not more, of these qualities, because it comes with the training. Do you understand? It is part of who we are as professionals. We pay attention to detail. We sweat the small stuff and we absolutely fear failure. We are obsessed with what we do. If you don't get that millimeter right, you will keep thinking about it and wondering about it. Is it going to be okay? Is it not going to be okay? So for those qualities, I mean, we are already possessing some of the attributes of great entrepreneurs. We are perfectionists, there is no doubt. Because if it's not 100%, we're not accepting it, right? Now, that was just an introduction of why do I think that as dentists, we make such great entrepreneurs. Now we're going to move to the real reason why I was invited to come speak to you guys. How do we then move our practices into businesses? So imagine this, a hierarchy where we're going to navigate ourselves. We're all starting from the base, from the bottom, because when we qualify, that's all we are. We're just clinicians. But now how do we move from being just clinicians to being the business owners, right? So, like I said, when we're starting off, we're all just clinicians. We have a great solid foundation, We have a plan, because nobody goes into private practice without a plan. We have a plan, and with that plan, we have an end goal in mind. If we are lucky, we break even in business. But if we're not lucky, we make a loss. Yeah? And then we move on. As many months progresses, we move on and we develop our skill. Then maybe we learn to do a little bit more patients at a very limited space of time. Then we can move on to being more like self-employed. Now we are seeing the results of our hard labor. We're starting to make a little bit of money, if we're lucky, So, but now the problem is we have to be there 24/7. We are our own bosses. If we're not there, there's no business, you know? Because most of the time when we're starting off, yes, we can have a locum, no, we can't have a locum, you know, but basically we are the business. We are making it happen, which means when we're not there, there's no money coming in, right? Early days, trial and error. Now we say we need to move up the ladder. Now we have to be entrepreneurs, right? Which means we need to be visionaries. We need to be unique in our practice, because right at the base of the triangle, we are all the same, straight from varsity, just clinicians, right? But then as we progress, there has to be something that sets me apart from you, right? That's entrepreneurship, because you might have a lot of people offering the same service, but what makes you, you? What makes people come to you and not to me? Not to say we need to be competition to each other necessarily, no. But as an entrepreneur, you need to have those ideas that will make you stand out in the industry. We progress from being entrepreneurs, business is growing, we're doing well, it's all lovely. We start making a little bit of money. And then we say, now we want to become managers of our practices, you know. Some, obviously, they do start setting up multiple practices at the base of the triangle. It's good because we do not all have or possess the same qualities. Some people are sharp, they can hit the floor, the ground running, but some need to take time, you know. So you need to understand yourself, understand your qualities, understand what you are capable of. Do not look at Dr. S hitting the ground running and thinking you're gonna do the same. Because when you fall, it's gonna be ugly. Right, what do we mean now when we say we're managing our practices? We're now managing directors. It means now we are serious about this business thing, right? Not that we weren't serious when we started, we were serious, but then the responsibilities were not as much. The expectations from us as business people was not as much. The expectation from us as business owners wasn't that much. The only thing that was expected of us was, are we able to do the procedure? Are we able to do what is being asked of us? But now as you progress up the ladder, as you can see the triangle, guys, if you know that, understand, the base basically represents the magnitude. A lot of us. There's not a lot of us up there, you know? So do not be discouraged when you hear. Just run and walk in your pace, no pressure, right? Let's not put pressure on one another, right, guys? You know, let's allow ourselves to grow. Right. Managing directors, thank you so much. You guys are so quiet, making me nervous. Okay, cool. Now, as managing directors, what do? We still take risks, but our risks are now calculated. There's more clinical work and much more administration. Right? We have to have systems in place because when you are a manager, the expectation from you is so much more. Everybody is now looking up to you. The lady who cleans and mops the floor is looking up to you for the answers. You know, the dentist or the fellow colleagues that you employ are looking up to you for the answers. The accountant is looking up to you for the answers, right? So you understand the pressure. Hence, I'm saying, as much as you love being hands-on, because of the rank of where you are forced to shift just a little and concentrate more on the admin rather than being hands-on. But it doesn't end there. We can also become CEOs of our businesses. Okay, So now what does a CEO, when you think of any big business, what does a CEO do? We hardly ever see them, you know? They're always attending meetings, briefings, you know, reading reports and doing reports and all of that. So the CEO is the person who says, as much as you're not there, I'm not there rather, I am out there selling the business, not as a marketer, but I'm saying I have the numbers with me. I go out and I look for investors and I say, this business, it's no longer a practice now, right? Now it's a business. This business can offer this, can offer that to the market. Probably looking for investors, or if they already have the investors, they're now convincing them why they need to stay with the business. So basically for the CEO, all the decisions that they make are based on the reports, you know, they're not based on them sitting there looking at one patient there, one patient there. Most of them have all their decision being made just by looking at their computers. It doesn't end there. We can now become business owners. What do I mean by us becoming business owners? I mean, now the business becomes an asset, right? You know what asset is? Something that puts money in your pocket. You know, that's what the business is now to you at that level. Well, personally, I haven't met a lot of us who are at that level. That means I can go on holiday for 5 years and nobody will even know that I'm not there, but I'll still be getting paid. That's the tip of the iceberg, so to speak, you know? It's so tiny, it's so small, you know? Most of us at the self-employed stage, don't get confused, right? There is, I own my own business, and there's a business owner, two different things, right? So, business owner, you know, doesn't matter, money coming in, just money coming in, no worries, you know. Maybe he doesn't even remember that he was a dentist at some point. Okay, so now how do we navigate through this corporate landscape? I want to talk about different types of entities that are available for us. Okay, for anyone who wants to go into business, not just us. But I'm going to keep referring to us because, I mean, it's about us. There's two different types. We have a formal, informal sector, right at the corner there. We're not bothered by it at this stage because who are we? We are the guys that are navigating through the triangle, right? So an informal sector will probably include maybe someone selling like a street vendor, you know, they don't need to be registered, you know, whether they do their declarations or not, nobody cares, nobody's asking questions, you know. Right at the corner, okay, topic for another day. I want us to look at the formal sector. We have three that I would like to discuss. The sole proprietors, private companies, trust. Actually, there is another one, you know, where maybe we should put it at the corner there, right at the bottom there, saying, maybe let's call it a holding company. I'll explain to you why is it that we need to also speak about this holding company, because we're not going to get to the tip of the triangle if we do not look at other options that are available to us as dentists, you know? Right. Most of you guys, I'm sure you already know this, so I'm just gonna move through it very quickly. The sole proprietor is basically could be an individual, just one person, or it could be two people coming together to decide and form a partnership, but still trading as individuals, you know, within this partnership, which means their liabilities and tax implication are based on, you know, the individuals. And then there is a private company, like small businesses. We have the CCs, the PTYs, and the Inc. With the trust, we have a donor and the trustees, meaning the person who sets up the trust and the people who are beneficiaries within the trust, right? You can operate a business from a trust. Very complicated story. Okay, like I have said, quickly, a sole prop, it's unincorporated business. It could be an individual or it could be in a partnership. Without the owner, there is no existence. Second block of the triangle, I'm my own boss. Most of them, or most of us who are sole proprietors would be, you know, in the second triangle. We are responsible for the debts and the obligations, which means you and the business are one. If the business goes down and you have creditors, they have every right within the law to come for your assets, right? It's a very dangerous position to be in. There is no registration formalities that are required. There is less paperwork, less admin, and you are taxed on a personal capacity, right? Well, it's mostly the same. I would say the characteristics of the sole prop are exactly the same as in partnership, except for now it's more than one person. What I need to point out here is that the recommendation is that the partnership does not have more than 20 members. 20 is the maximum, which kind of makes sense because, I mean, you know, it could be a very complicated thing to manage if there's a lot of people within the partnership. When you engage or when you decide to go into partnership, it's very important that you have an agreement in place. Everything needs to be stipulated. You know, you don't just say, Dr. Sbanbane, we've been friends or we were classmates, we understand each other. Because when it ends, remember, you and the business are one. You may be the responsible one, I might be the irresponsible one. But if the business fails, it means you and I go together. What are tax implications for the sole prop? According to the Tax Administration Act, the minute you generate an income, right, you need to register. If not, within 21 days, 21 days, not when someone asks for your financials, then you say, oh, by the way, let me. Within 21 days of you deciding you are setting up a private practice, you need to let the man know. There are different types of taxes that you, or tax types that you need to be registered for. Income tax, the VAT. I will explain as we go through, because, you know, at the beginning, you don't necessarily need to have certain types of tax. Income tax, PAYE, SDL, ETI. So the PAYE, the UIF, the SDL, and the ETI, they fall under the payroll category. If we're saying we're moving up the triangle, so you must always keep the triangle in mind. If we're saying we're moving up the triangle, maybe at some point we need to register ourselves for customs tax, as well as capital gains tax. Right. There is two tax systems available. There's a turnover tax system and an income tax system, right? The turnover tax system, basically it says, I will declare and I will pay my taxes based on the turnover that I make. There are limitations to this. You need to be turning over less than $1 million, right? Once it's more than $1 million, then the turnover tax system, you no longer qualify. Number two, you cannot be a professional service provider like us. We no longer fall under that category of a turnover tax system because the nature of our business, it's the professional services. We, however, fall under the income tax system, which if you are a sole proprietor, the tax is quite steep. I didn't have all the brackets listed there, but just in passing, you can be taxed up to that very last line there, 45% of what you make, right? So when you're looking at maybe that doctor is making over 1.6 million, you will be taxed 587,593 plus 45%. But now this 45% is not the 45% of the whole amount. It will be the 45% of the difference from the 1.6 going up. So let's say you are at 1.2, right? So it means you will pay based on this, you will pay that. So if you're slightly more, then you'll be taxed 45% of the more. I'm sorry, I'm blocking the screen. Hey. Anyway, you get the picture, right? Let's move on now to the private company. The examples, like I mentioned, your CCs, your inks, and your PTYs. But the private company, it is exactly that, it is private. You know, you cannot trade in an open market, which means you are now limited in moving up the triangle. You can go up to a certain point. Because if you're private, you are restricted as to who you sell your shares of the business to. Make sense? Right. You can have one owner up to a maximum of 50 shareholders, right? You need to have an annual meeting. Obviously, if it's more than one shareholder, you need to hold at least one general meeting. And then we have an incorporated or an Inc. Well, an Inc is slightly different. You will see when we get to the summary of all the types of entities. With the Inc, the type of tax that you pay is mostly on a dividend tax, right? It's not on income tax, which means you do not get excuse me, you do not get taxed on your income or your profits. Okay, dividend, it is kind of a profit, right? But you are taxed on dividend, which means I am a practicing doctor who decides I want to have a company or want to have a registered business. I am trading myself as a doctor, right? So how do I pay my taxes? I will declare dividend from my Inc and pay 20% because dividend is 20%. Okay, there's further classification of private companies. At this point in time, it's not really relevant, but we don't know, because if we're moving up the ladder, we don't know what are the requirements as you move up, you know. We're talking of now the EMEs, where you're making less than 10 million turnover, or we're talking QSE, making 10 and more, or the generic, which are the big guys now who are turning over 50 million plus. Okay, the BEE scorecard currently with us. You know, there hasn't been any talks around it. But remember, if we're saying we want to move up, we want to diversify, because you know what? Here's the fact. Most private companies, they want to do business with the companies that are BEE compliant. So it would be nice to position yourself to be BEE compliant. Now, I'm not just talking you being a dentist, just servicing the patients. I'm talking you being more than just servicing your patients, you know? Okay, I've already mentioned that on the turnover tax system, if you are making less than $1 million, you are taxed, the turnover tax system is not relevant to us, but you are taxed 1.4%, which is a very sweet deal if you ask me. I don't know why they didn't include us there. On the income tax system, as a private business, you are taxed up to 28%. And then for the Inc., it's sitting at 20%. Okay, I'm just gonna skip this slide. Okay, maybe briefly about the trust. It needs to have a minimum of 2 trustees, right? And the benefits of the trust is it holds assets and it protects them. But there has been rumors and talks around, you know, because now they're seeing that people are more interested in moving all their business interest and assets into the trust, because at some point the trust was sort of like untouchable. You know, you'd accumulate all your assets and then you hide them in the trust. But now they're looking into it now. So I think as from, if you've had a trust up to 2014, you're okay, please don't quote me on this, it's not a fact. You know, it's just the things that I've been reading and hearing. But after the year 2014, I don't think you'll still have the benefits as the people who had trust prior to that. So the advantages of a trust are, there is more option for income distribution. It minimizes the tax. It operates the business with more privacy, you know, because that's where people were hiding everything. No one was asking them anything because you'd say it's in the trust, then it stops there. It does protect business from, okay. It does protect the business from the beneficiary's bankruptcy. The disadvantages of the trust are it is very expensive to manage it. It is such a complex type of a business to own. You know, I don't think there is, unless if they specialize in trust, there's one person who can say, I know exactly how a trust works, unless if that's what you do every day. So you can, I don't think you can possibly do it on your own. You're gonna need someone to hold your hand. But now, what made the trust to be a better point of trading? It's because it uses something that is called a conjugate principle, you know, which means it distributes the income and the capital gains to the beneficiaries. And then the beneficiaries pay tax. Can I make an example? Let's say, as a trust, you have made maybe say 7 million and you have 7 trustees, right? And then you say, instead of paying 45% of tax, you say, hang on, I have trustees. You take that 7 million, you distribute it amongst your trustees, which means each trustee will get 1 million, 1 million, 1 million. And then the trust can say, well, as a trust, we did not meet the threshold of the tax, which means we are tax exempt, right? And then the beneficiaries will pay only 20% because they are paid in distribution of income. So that's how the trust was working, and that's how people were getting away with not paying so much tax. by operating their businesses in the trust. Now let's compare quickly in summary. Okay, for sole prop, no formalities. Private company, yes, there are formalities because you need to register with the CIPC. Trust, you need to register as well. Liability, sole prop, unlimited, you know. Private company, it is limited. Trust, very limited. Tax implications, if you are a sole prop, you can pay up to 45%. Private company, 28% for the CCs and the PTYs, and 20% for the Inc. The trust can pay up to 45%, but now this is how they got away with it. Remember, they were using the conduit principle to say before we are even liable for that 45%, let's just, you know. Okay, in terms of the number of members or shareholders or the trustees, for the sole prop, it could be 1, but in partnership, maximum of 20. Private company, minimum 1 member or a director, up to a maximum of 10. PTY, up to a maximum of 50. With the Inc, there is no limit. But then with the Inc, it will make sense if you are registering for an Inc if you are all in the same profession. Because can you imagine incorporating with, I don't know, a lawyer? Maybe you can, I suppose, you know, but I think it makes sense if you are incorporating and you're doing one thing. So for a trust, there is no specified number of trustees that you can have, which means there's no limit. Now let's quickly talk about the tax rebates and the tax types that are available. Remember, I promised that we'll talk more on the income tax, the VAT and all of that, who should register, who shouldn't, and why. So the income tax, all of us. If you have an income, you need to be income tax registered. For the VAT, if you're turning over 50,000, you can do it. You don't have to, but you can do it if you want, which means it's voluntarily. But however, once you hit that 1 million mark turnover, it is now mandatory. Whether you like it or not, you need to be VAT registered. Pay as you earn. If you employ anyone in your practice and you're not registered with the pay as you earn, PAYE, you are breaking the law, right? UIF, you need to be registered if you have employed someone. You contribute 1% and the employee contributes 1%. With the customs tax, it's when you are now diverting into importing or exporting goods. In our case, it would be most probably dental goods. It could be consumables. It could be chairs, instruments, whatever it is that you might be interested in importing or exporting. With the capital gains tax, if you are disposing of any asset, you need to declare, you know? So if I buy this mouse for 10 Rand, you know, say it's, maybe its value goes up. If I buy it for 10 Rand and sell it for 12 Rand, I need to pay tax on the 2 Rand because it's a gain. Make sense? Right. Dividend tax, it's when a company pays you a portion of your profits and you have to declare and you are liable for 20%, up to 20%. Now let's talk rebates. There is something called medical aid tax credits, right? So if you have a medical aid, the man says, okay, that's one less person you need to worry about. Their health is taken care of. So they incentivize you for it. Not that they put money in your account, guys. No, they don't. But what they do is they say, which is something that you declare on a monthly basis, right? They say if you are the main member, plus the spouse or dependent number one, let's not necessarily call them a spouse because it could be you and the kid. So the main member and the first dependent, they incentivize you with 332 Rand per month, depending on how many number of dependents you have on your medical aid. For each additional member after you and your plus one, you get 224 Rand. The ETIs, which is the tax, employment tax incentive, basically they were looking at how can we motivate businesses to hire young people, right? Because of a high rate of unemployment. So they came up with this ETI where they say, on your PAYE liability, if you employ someone who is between the ages of 18 to 29, we will incentivize you by giving you 1,000 Rand off. So let's say the person that you, because most of us here employ young people, right? So we can actually benefit by claiming back the ETI. If you are paying them between 2,000 to 4,000 Rand, you can actually take off 1,000 Rand. It's not that it's money that is coming into your account, but when you submit your EMP 201, which is your pay as you earn, UIF and SDL, you take away 1,000 Rand per employee. So if you employ more, you do the math. The SDL, you contribute 1%, but you can't claim the SDL, but this is where you benefit from the SDL. There are things called SETAs, different SETAs for different sectors. If you are paying salaries over 500,000, you have no choice but to be SDL registered. But anything less, you do not have to. That is if your salaries that you pay out to your employees go over 500,000, then you have to be registered with the SDL. How do you claim this back? Right, with the SETAs, through training of your staff. So we train our staff, but we don't use our money. Wink, wink. You see where I'm going with this? Right, now let's do some practical examples to see if you guys have been paying attention. So some of you guys here were my clinical supervisors, some were my lecturers. It's payback time. I hope there's no one called Mary here. I chose Mary because Mary happens to be the name I wish I had. So Dr. Mary is a newly qualified dentist in private practice. She employs 2 people. Her turnover is 950,000, and she makes oh, she's doing well. She's making a profit of 250,000. Let's advise Dr. Mary on these 3. Should she go for a turnover tax system, income tax system? Should she be VAT registered or not? Should she be trading as a sole prop, or she needs to consider registering a business? Anyone want to help Mary? Mary's on her own. Come on, guys. We can't do this to Mary. She's looking up to us. Yes, Doc?
Okay, so what to do?
Mm-hmm. The doctors are saying no. Uh-huh. Mm-hmm. Mm. Mm. Okay, if Dr. T wasn't married, that's what he would do. Who else has a different opinion? Yes, Doc.
I think in this case, that obviously is out of the question for now.
Mm-hmm.
And then turnover tax we cannot consider it professional. And then our advice for a private still, I think 45% of that amount is very good.
Okay, so except for Doc, just to clarify, it's not 45% of the 250.
Not of the 250.
Yeah.
Of the turnover.
Yeah.
Because we are not going to, as a sole prop, we don't talk about profit, we tax on profit.
Mm.
You are being taxed on the whole. So that's quite a good chunk.
Okay, all right. Okay, there's a different view.
Mary has a chance to grow. You gotta say, I would advise Mary to go for an income tax system, register VAT, and go for a private company.
I would advise Mary as such as well, you know, because Mary is doing good. Mary is doing well.
She has a chance to grow.
You know, but at this stage, the answers given by doctors, they're absolutely 100% correct, you know, because it's different strokes for different folks. But if you're looking at growth, Mary has got potential. So we say, Mary, get yourself income tax registered, because turnover, you fall off, you're a professional. You have to get yourself VAT registered, you know, because in a matter of 5-2, you're going to be liable for VAT collection, right? So tax implications, like you said, Doc, it's quite high, right? So let's register her for a private company or an Inc., either a PTY or an Inc. Now, years into private practice, Mary now turns over 2 million and she makes a profit of 82,000. Mary, what happened? A lot of locum, I suppose. Because she was away on vacation and she had to pay the locums, then maybe that reduced her profit now. Maybe it's a different Mary. Let's not make it the same Mary because it's going to be confusing. Let's call her Bettina. With the 2 million turnover, 28,000 K profits, sole prop, private company. When you're looking at a point of the potential and growth, yes, definitely private. But when you're looking at the tax implication now, Bettina, you can be whatever the hell you want to be. Because at 82,000 Rand profits, nobody's asking you to pay no tax. Make sense? Because it's brackets, right? Okay, let's move on. Now let's go to Pretty. Now Dr. Pretty is in years in private practice, turning over 3 million with the profits of 1.2. Inc, CC, PTY. Okay, the CCs, you know, they don't register CCs anymore. So maybe let's say Inc, PTY. Inc, wow, you guys are good. Why Inc? She pays tax on dividends, 20%, versus income tax, 28%, 20%, right? Mary, Bettina, and Pretty are in good hands. Now, let's move on to some exciting stuff. By staff, I mean literary employees. That's what I mean, you know? Because they are an asset to our businesses, right? And we need to do right by them. Because if we look after them, they will look after our businesses. In fact, they will give us the push that we need to climb up the triangle. So this is my recommendation. It's not cast in stone. It is my recommendation. Then when you are employing someone, you stick to the basic conditions of Employment Act. Do not try and tweak it so much because even you can't keep up. And should you be taken to task, you're just referring back to the basic Employment Act. Keep it simple, right? I know sometimes you wanna, be understanding and be flexible and allowing, but listen, if you don't remember anything I say today, keep it basic. Because there's that other man that we often every now and then get invited to. And this is the document they use. So stick to it. You can have a standard contract, or you can have a limited duration contract. It could be based on a project, or it could be based on maybe someone going on maternity leave where you wanna offer someone to come take over the spot for a couple of months. So you need to be very, very clear on the terms of that employment. Because if you're not clear on the type of contract that you're offering your employee and there's misunderstanding, I promise you, you will lose. And if it's a fixed contract, a month before, you need to notify them. You remember what you were not full-time. You were just part-time. You need to remind them in writing, not corrid, and say, in writing, it has to be documented and filed. Because if it's not, and you go past the 30 days notice, you will lose, I promise you. So the basic conditions of employment, they will clarify the leave, the sick leave, the maternity leave, the family responsibility. I know, we have extended families, when I make your family responsibilities 100 days. Don't. Stick to the basics. It also will talk about the notice. How much time should a person serve as a notice? 1 week if they've been employed for less than 6 months, 2 weeks if it's more than 6 months but less than a year, 1 month if it's more than a year. However, sometimes you get those potatoes that just slightly go off. And you're like, okay, now what? Then they serve you with that notice and you're like, there's a God. You are allowed to say, you know what, my dear, I hereby release you of your notice. You don't need to serve your notice, but pay them for the notice. If you're the one that's saying don't serve, you pay them for the notice, because if you don't, you will lose. You may withdraw monies from an employee on these conditions, right? If the contract says you need to give a 30 days notice, and you give me a 30 days notice, but you don't serve a full 30 days notice, legally, I'm allowed to withhold monies that are equal up to the period of the notice. It is within my right as an employer. I know sometimes we get bullied, and because we're so busy, we don't want to engage or get into it, we pay number. But legally, you can withhold money, not sticking to your end of your contract. Also on the basic Employment Act, there's something called COIDA, which is a Compensation of Occupational Injuries and Disease Act. If you have anyone working for you, you need to have this insurance. This will protect your bank balance, not you, but it will protect your bank balance. Because imagine this. You ask Noma Sonto to go mop the floor, and Noma Sonto sleeps and falls while performing the duties that you've allocated to her. She's well within her rights to say, injury on duty. If you don't have that insurance, no matter how big or small your company is, if you have people you call employees within your business, you need to be insured. They need to be insured, because if they claim and you're not insured, it's coming out of your pocket, right? Incident, I'm not going to mention the time. Receptionist, we're busy working, and then we hear, what's happening? She fell. And I'm trying to understand, how is it even possible? Did you jump over the reception desk to get to your chair? Or, because all she had to do was just to sit her behind down. How does she fall? You know? Let me just say, thank God for the cameras at the reception area. Right? Because now she was preparing herself to claim injury on duty. And if you don't have the insurance, how do you prove it did not happen? If you don't have, I'm not suggesting you put cameras, but I mean, I had to. Otherwise, probably I wouldn't be standing here, you know? So what I'm trying to say is, it's very important to make sure that when you have people working for you, you do take insurance. So how is it calculated? It is calculated based on the salaries that you pay annually. They work out a percentage and say, out of the salaries that you pay, the percentage is going to be so much, and that's what you pay. You do it once a year. It's very important to keep the good stuff, keep good employees, and don't be shy to let go of not so good. But you need to do it in the right way. What is the right way? Keep record of everything. You know, we tend to be so understanding. You know, we tend to be so relaxed, and then they take advantage. No matter, even if you're not planning on getting rid of anyone, keep record. They come late, you keep record, you know. They, I don't know, commit any sort of offense, you keep record, because you don't know when you might need it. You might never need it, which is great, but then you don't know. So how then do we make sure we keep the good stuff or employees? First of all, we hire the right people for the right jobs. Then we take care of them, and they will take care of your business. Or maybe they won't. Irrespective, you do the right thing. You offer training, but remember, SDL, we are going to offer training. We're not going to use our own money. We're going to use the money from the seaters, right? But it still looks good on you, because when you work for Dr. S, you go for training. We went for training for this, training for that. So, you know, it gives you a good name out there. Meanwhile, it's that seats are working for you. It is important to be registered with all the regulatory bodies, UIF, Workmen's Compensation, and HPCSA, because our dental assistant needs to be registered with the HPCSA. When you do employ the people, you need to orientate them within the business culture. Your missions and your visions for your business need to be clear, which means the triangle that I've been talking about this whole time, it doesn't end here. You take it back to your assistant, you let them know, this is where we are, this is where we need to be, right? You sell your dream to them, and hopefully they buy into it. We need to systematize the stuff, which means the delegation, right jobs, right people. Vetting is very important. Not a lot of us actually phone our colleagues and ask for references. We don't, you know, you just need someone, you put up a post, you hire, and you move along. You need to vet people, because people have history, and you know what? They more often than not do repeat the tendencies, you know? So if I got struck by this lightning, make sure you don't get struck by the same lightning. Having said that, it is illegal, guys, to give a negative reference. Yes. If I was looking for a job and I'd listed you as my reference and my potential boss calls you and you tell them I came late, came to work drunk, didn't do my job, I can turn around and say, I want to sue you because you closed doors for me. That was an old me. I've changed my ways. You rather say, I am not comfortable giving reference. You stop there. It is illegal, guys, to give a negative reference, rather not give a reference. So when you call me and you ask for a reference and I say, I'd rather not, read between the lines. It's true. And don't be shy, guys, to let go of people who are not buying into your business. It's okay, you know? But you do it the right way. You follow processes. Like I said, documentation, keeping record, right? Doesn't matter the offense, big or small, you keep record of it. Because if someone is not buying into your dream, eventually you want to say, look, here's your file. This is you, 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 this is you. Therefore, I'm giving you a notice. But you know what? I'm just going to pay your notice in advance and then you shake hands. Then you are protected. You don't just come in one day and you say, hey, you can't. You will lose. So here are some of the offenses. It would be dishonesty. Like for instance, someone lying in their CV. You know, serious offense. Trust-related offenses. Attendance time. Labor says we can't give notices for people who are showing up late for work. It's there, black and white. Offenses relating to conduct towards an employer, a co-worker, or the public. You cannot be rude to the clients or the patients that are walking through the door and expect you will get away with it. You know, you don't say, don't do it again. You say, don't do it again, but keep record. Duty-related offenses. Funny story. Mr. Daddy comes into my practice. He has an appointment for 3 o'clock. And I'm saying, okay, tomorrow I'm seeing Daddy for root canal treatment. And then I start having sleepless nights about it. And I'm thinking, yo, come 3 o'clock, Mr. Daddy comes in, sits on the chair, open the canals, clean. This is a more on a serious, you know, scenario. Open the canals, you go in there, you're confident, you're feeling yourself like, yeah. Time to obturate, there are no GPs. Duty-related offenses. Written warning. 2 of them, that strike, you are out. If you don't, you just say, you will lose. Abuse, misabuse, negligence, it's an offense. You keep record. You'll never know when you might need it. Occupational health and safety offenses. I mean, how many times have you been handed an instrument that is not so sterile? It's an offense. You keep record of it. Now, disciplinary codes. You can give a verbal warning. That depends. It depends on the extent of the severity of the offense. You give a verbal warning. 2 written. 3rd one, you out. You issue them a notice of a disciplinary hearing. You don't just say you've had 3 notices. Therefore, you issue them with the notice of a disciplinary hearing. 7 days prior to the actual disciplinary hearing. And they need to have, if they wish, a representative or an interpreter. Then after the hearing, you give a report and they have a right to request an appeal. So it's such a long process to actually get rid of someone. It's not a matter of, wena, it's a long process. Because if you don't, they will take you to the man where you're no longer in control, CCMA or labor. So normally it's CCMA if it's one person, labor if it's a group of people, you know, then you go through those processes. So, you know, when you have a representation, it will save you time, but cost you a lot of money. But if you have your records, you just pull out your file and you take your records to the man, right? Now, how do we now raise capital for our businesses to make sure we grow? In 2021, the Banking Association actually said that us at the base of the triangle, the small businesses up to the medium size, we contribute 91% of formalized businesses, which means they are taking us serious, right? We provide employment up to 60%. It's not the big corporate, it's us that provide up to 60% of employment, which means if we're out of business, that percentage drops and it looks bad on the GDP of the country, which means to a certain extent, they have to look after us. They need to make sure we have everything that we need, but we also need to do our part. We can raise capital by loans from the banks, but then it means you need to have all your financials in place, audited financials, preferably. We can allow buy-ins from the investors, but it excludes the sole proprietor as well as the Inc. We can also do something called factorizing of books. I know I'm running late, but can I just quickly explain, because this is important. What do I mean by factorizing books? You have over a year, patients that owe you, from the shortfalls, from patients just receiving the treatment and never coming back, And then when you look at your bad debt, it's sitting at 1.2 million. That's 1.2 million sitting with the patients. What you gonna do? Hand them over for collection? Good luck. Or you can factorize the books. You can say, but on the factorizing of the books, you need to be a formal business. You need to be a registered formal business. Where you go to either the bank also factorizes books. You go to the bank and say, okay, bank, whoever company that factorizes books, and you say, I want to sell my books to you. I have this list of patients who are owing me this much money and they're not paying. So I'm going to sell these books to you. Obviously, you don't get the 100%. They do take a percentage. They have their ways of collecting. I'm not bothered by it. Then you also need to utilize the incentives that we spoke about. Your SDLs, ETIs, you use them to make sure that you develop your employees, not that you keep the money, because as part of growth, some of the money that you make, some of the incentives that you make, you invest back into the business. And also we can insure the debtors. In our case, it will be the patients or the clients. What do I mean? You have a patient coming in, they want to have an ortho done, right? There are companies that you can have that will do a credit check on the individual. The very same companies do also offer the insurance to say, Dr. S, patient so-and-so can afford 60,000. If you decide to give them a treatment that's worth 65,000, you lose out on your insurance. But if you stick to the limit that they found during the credit check, they take the risk, not you, because they said, we have done a credit check on this individual and they're good for it. So if they turn out they're not, because most of the time they are good for it, they just choose not to pay. So you take that responsibility and you give it to the insurer and say, I have my debt insured by you, and you did a credit check and you recommended that I can give so and so a treatment up to the value of so much. Now they're not paying. I want my money. Then the insurance will pay you, but it doesn't end there. Then the insurance deals with them. Now, how can we just diversify within dentistry? We can have buy-ins or collaborations with the switching companies. I'm not going to mention any company. We can collaborate with the IT companies and develop apps, dental apps specific to us. We can buy shares on the JSE listed medical aids, actually. We can go into property development projects where we're saying, okay, in every practice that I set up, I buy the property, I don't rent. We can go into imports and exports of goods. Also offering peer training and development, to your peers. You have to obviously have certain types of registration so that you are able to do that, but also it is another stream that you could use. Or practice management services. Now, this is where the holding company comes in, because all of this, it has to have some sort of registration, You can decide to say, okay, for my import and export company, I'm going to use company X. For my actual chairside dental treatment, I'm going to use company Y, but I'm still the owner of all of these companies. So you pull them all together and you create one holding company. What is the benefits of the holding company? Just because you got 10 rand, 5 rand, 16 rands, it doesn't mean you pay the total of these amounts, because each entity pays tax individually. So by the time it gets to you, it's already done. In conclusion, growing our practices into big business, we will need to understand taxes and incentives thereof. We need to ensure that our companies are in good standing with the statutory bodies. We need to create systems within our businesses that will facilitate growth. We recruit, train, and delegate staff accordingly. Like I said, greatest asset you could have. We also need to invest in systems like your payrolls and your accounting software so that we don't outsource a lot of these things. We have it done in-house. It will save us a lot of money. In creating systems, just in passing, when COVID started, right? And the masks were a thing. I discovered that because of my big mouth on entrepreneurship, I had created an entrepreneur within. Do you get what I'm saying? Because I always say, you're young, you need to. Meanwhile, they're looking at the stock and dog, you're right. You know what I'm saying? So this is how you control it. Purchase order, right? You communicate with your suppliers and say, if it doesn't have a purchase order number, it's not bought by me. Because the purchase order number is going to start from 1, 2, 3, up to whatever, So when you receive the goods, you check against the purchase order and you say, yes, I bought X amount of gloves or X amount of masks. So the invoice needs to speak to the purchase order and speak to the statement at the end of the month. If there's a discrepancy, and after you've sent out the communication to the suppliers to say, all my orders are going to have a purchase order. If it doesn't have a purchase order, it's invalid. You can't have a duplicate purchase order because you have a system in place that says purchase order number 4 went to this supplier, purchase order number 5 went to this supplier. So needless to say, that was the end of the entrepreneurship that was going on within my practice. Now, in closing, all I want to say is we work hard for our money, guys. So we need to make sure we keep most of it, if not all of it, the legal way. These are the references that I used to come up with this talk. There are other references, the voices in my head, not those voices, the other voices, but I couldn't list them as my references here. But it would be interesting for you guys to find time and go through some of these reads, quite good reads. You will learn a lot from it. Thank you so much.
Before I officially thank Dr. Kambo, I would like to make a quick announcement to everybody who's here.
Can I
We still
disconnect?
have a last speaker to go.
Can I disconnect here?
Is that your laptop?
From here,
That means the person who's coming next will have to connect this.
Oh.
So yes.
There were a few people who might
So
have not
much.
been aware, but we do have our first class of dental therapy, 1977 class. So everybody's welcome.
She was
Come
taking her
join.
laptop.
And
Whoever's coming will have to bring
awards.
theirs.
And then,
That's why we don't have it there.
yes, and it's not format. And have a bit of a sit down and chill session and all the project of that. So yes, everybody is welcome to come up there after Dr. Mtambo.
Our practices, and we are going to move to greater heights. Thank you, Dr. Dudu. Guys, we saved the best for last. You had the first one, now we are giving you a knockout punch. Let me call Dr. K, as we know him, Dr. Kubezi Mukwele, to come forth. It is not that we are both from Eastern Free State. It is not that we are both in love with Endo. It was the executive decision. But Dr. Kumeti, he obtained his BDS from the University of Witwatersrand in 1996. He is currently a founder and director of Sunset Dentistry. He has expanded his clinical and practice management skills over 3 other practices, including the Sunten and Foy's practice. He is popular in Joburg. You know him as the person who's against the goal. He is very popular in social media. I wish I could avoid saying next to Zodwa. You know Zodwa. He is very popular in social media by taking exciting photos and videos of his patients. And I think we are going to benefit from his session today. And it is termed, we are making the second bigger. So just ask if the second is going to be bigger. We'll see and we'll hear from him. Let's welcome him again with an applause.
Okay. Great. I don't know what to do. Organization. Yeah. Thank you, colleagues. Thank you, Dr. Mtambo, for formalizing the madness that I'm about to present here. At least colleagues have guidance on how to do it properly, because this one is touch and go. Some days you win, some days you lose. This business. We are all in our businesses and we know the reality. So let's see how we manage to. My lecture is about strategy around my business, growth a little bit, and to a certain extent I'll be very honest about figures. Okay, not entirely honest, but very honest. And then, but then it's about sharing ideas. Or if I am slightly ahead this year, someone could be slightly ahead next year, and they can tell us how they did it. So. Just a disclaimer, I also have to admit some of it is, I started several practices and even moved from the Free State because of my ADHD, where I can't stay in the same place all the time. So you'll forgive me if it kicks in while I'm going on. And the sabotage here. It is, is anyone who knows computers better than Dr. Ted? So let me tell you about my history. I qualified 96. I worked in Kwakwa from 96 to 2013, and I moved from the Free State. By the time I was moving from the Free State, I was already practicing from Kwakwa, Bethlehem, and Bloemfontein. And so I had reached the ceiling, I thought, and I decided to come and work in Joburg. I didn't sell anything. The practice was not sellable because I had partners, and I just cashed in on the properties that I had purchased and was servicing the bond for. And I came to Joburg with about 750,000 rands in cash. And within 6 months, that money was finished. I sold my car that I had at the time to be able to pay my children's school fees. And at the time, I think I have a stick. Let's back up here. Yeah, there's a stick in there. So around June 2014, I had a car for 8 years and I didn't owe any money on it. And I sold it because I had to pay my children's school fees. And as I walked into Joburg, I was working at NHC. I worked there for 4 years. I call it the University of NHC because that's where I learned about how to do business in Joburg. It was tough. It was like back at varsity. And so basically, I've had up and downs. And then in 2015, I even had to resign from the DPA. I don't know why they don't include in my CV that I was part of the DPA exco. What. I mean, I could say I have an MBA, but because I was at varsity with Dr. Sekho, but ADHD, then I've dropped out, but I have 8 months MBA. And then, I don't know why Dr. Mtambo had to outshine me because everything that I tried to and I dropped out of, she had to finish. I mean, I tried doing endo in 2008 and okay, I dropped out. So, but we are where we are now. Thank you. And I remember when I was doing one assignment I was doing with Dr. Seho, UOFs, and our computer picked up. And we didn't pass that assignment because we said, no, technology is saying you're supposed to have backup. And we didn't pass that assignment. So at least now I brought a stick. If Dr. Tadi knows how to use it.
No sabotage, or you're dead.
Interpretation. So I worked at NSC from 20. No, there's another one that's okay. There is a PDF one, and then. No. Are you sure it's PDF? No, it looks like there's two. No, the other one was not PDF. The one on here was not PDF. The one that's here is not PDF.
Yeah. No, then
Yeah, but it's in PDF.
I'll transfer this one to be a PDF. Yeah, the PowerPoint.
Oh, okay.
So this one.
Oh, okay. Oh, to the stick. Okay, sharp.
Transfer this one. Save first.
You can even save it on mine. So there's a slide in the presentation that says sometimes you have to be to be hit harder and go lower than you ever been to be able to stand up higher than you ever were. I can just give you highlights of where I think I was a bit low in my life. Number one, I got married at 27, and that's a low in your life. I mean, imagine when you see a 27-year-old and you say he's head of family. I mean, really, honestly. So, and then in 2000, and then we were talking earlier with colleagues about setting up side hustles outside of dentistry, trying to say you will make more money, you'll do this, you'll do that. So, I started a lot of businesses to employ my childhood friends, because when you buy people alcohol every day, you say, guys, I am tired of buying you alcohol. So let's set up businesses, and then we have companies, and we do this. And then that was a disaster. So it ended up with another low, because 2001, I was listed everywhere. Just as part of entrepreneurship and the hustle that's involved in it. I spent the last, I don't know, I think 70% of the last 20 years listed adversely on the credit bureaus. So it's been a real hassle the last 20 years. And no one sent me to do those things, but it is what it is. We end up there. In any case, so we can flip from here. Okay. So it is what it is. We've been up and down. So it's nice to say this year, this month we are up. We don't know about next year. It's life. I mean, the clock goes like this, so let's accept it. Okay. Thank you, Dr. Tadwar. Sharp. So I'll explain about make the cycle bigger. We'll go fast because I would like to make room for questions as well later on so that we can. So we'll discuss strategy about how I got the business to where it is, and we'll discuss figures, and we'll discuss the business overview. That's a bit formal, and we'll just go quickly through that. So that's my bio. 4 branches. The first branch was in 4 ways, started in 2017. The second branch was in Soweto, started last year, carried 2 March. And 24 days later, Ramaphosa said we must close everything. So, and I had employed 6 new people, so it was very frantic. And then now we have 14 dental chairs, half of them are second-hand, and don't worry. And then the other half are Chinese. So, okay, sharp. I'll get used to this. And then the origins of most businesses like Amazon, even some of the local ones, of course the honest ones, is to identify gaps in society, innovate ways to fill the gaps, and then make business out of that. And then that's, I mean, Mark Shuttleworth, who's this? Zuckerberg. He didn't set up his business to make a lot of money. He was on campus, and he was one of those chachara students that wanted to, maybe get girls by having all their photos and numbers, and then he ended up with Facebook. So I made that example as well. Basically, that's what it says. And he just wanted to have a mode on campus for people to be able to stay in touch. So he was one of those chachara ones. And then I, among others, this is one of them. These are some of the reasons I decided to start Sunset Dentistry. But the third one that I didn't include, which is true, is the fact that when we know we're going to get tired, and it's very tiring. And if you are doing very well the same procedures that you were doing 15 years ago, then you need an award when we come out of here in the award ceremony. Because I can tell you honestly, my clinical skills have deteriorated in the last 5 years. It could be fatigue, it could be lack of focus, it could be other things, or just getting old. I'm 50 next year. So anyway, the other one, I'll explain this in more detail. In 2000, I had a friend who was a lawyer. He was told if you could bribe somebody in the legal aid board, you might get a job at the legal aid board. You know, the one that does free cases? Yeah. I could predict from then that we are going to have the same problem in dentistry, where there's an extra amount of colleagues that, for one reason or the other, are looking for jobs, but especially young colleagues that don't have the business interest or capabilities, whatever. So I could predict that it was going to get to that. And when I started my expansion, I tried to do the same thing I'm doing now in the Free State. In 2006, I recruited several colleagues, like oral hygienist, 2 dental therapists, and 2 dentists. We had a business together, a partnership. It was because it was starting to become like that. There are many of our colleagues that are unemployed. So this is one of the things that motivated me to start the business. Then optimizing the value chain. If you have multiple dental chairs in a single set of premises, you can have one receptionist. Dr. Kumeleni always says it. By the way, he's the one who told me to leave the Free State and come to Joburg. I forget that. It was at another in 2013. So 2 months later, I was out of the Free State. I think I was feeling it as well. So you can have yourself and okay, let me say what you can do. In the same set of premises, if you can squeeze in a chair, you can now have the same one receptionist, one cleaner, one buyer, one whatever. But you will still now have 2 sources of income from the same premises. If you can squeeze in another chair. So if you can afford to do it, try and do it. It will give you an extra income with the same set of premises. Because sometimes I agree, some of us have offices. And in those offices, maybe if you're sitting in an office, you are being counterproductive because the machines and the handpiece is not running, you're not making money. So don't sit in your office. I mean, honestly. So own buildings by buying multidisciplinary practices. We'll discuss a little bit about that as we go forward. My practice manager, okay, I don't have an MBA, but my practice manager has an MBA. And he's got good skills in HR, he's got good skills in strategy, he's got good skills in, and he's doing me a favor because some of his projects were frozen by COVID. So he decided to come and help me out. So he's very good at a lot of these things. So we've got a guy that's doing our marketing, that's very strong with social media, and then we've got someone that's doing IT. So you can attract good skills. One IT person can service many chairs and many doctors and whatever. So multidisciplinary practices and multiple chairs in one set of premises and using one of each for all those chairs, you know, or multiple locations as the case may be. So this is a consolation. Remember, I may be saying this, I'm saying these chairs, what now? To be honest, we all know that half the things that we do not have, 80% of the things that were said here that are right, we don't have them in our practices. Again, you know it. We know, the lecture, tax, what, registration of this, we don't have that. So we mustn't feel bad, let's feel good. We have a business where it can start. I'm telling you, half the things that she was saying, I don't have that. I don't even, when she was asking questions, I'm supposed to be saying turnover, this turnover. I don't even know. I don't have it. So it's a start. Let's carry on from there. And then, but however, it says here shark in a fish tank will grow 8 inches, but in the ocean it will grow to 8 feet or more. The shark will never outgrow its environment. Yes. Let's talk about that. Let's outgrow our environment. It's profitable. Let's just accept that. So, but when you come to Joburg, you realize there are bigger sharks. We're coming from the free stage. Yeah, I told you this, and I didn't finish when I was telling you about me being down. So, as if coming here and having to sell my car to pay for my children's school fees, I mean, I'm a single father, so, and I don't collect pub health. So then I sold the car, and the children were back in school, and then 2015, I had to resign from DPA. I went for an op to remove a lump from under my skin here in the chest. It was a mix of fibrosarcoma. It's a locally aggressive soft tissue tumor. And then 2015 October, needle stick, I started taking ARVs, went into depression, and then I was down, almost finished. And then I was working at NHC, and at NHC, I am learning how to do the systems that are practiced by NHC, Intercare. So there were sliding scales, I never speak ill of them because we are where we are, you know. So it was, the chips were down and I wanted to go home. I remember telling my mother, and she agreed I must come home. At least my chair was paid up. I was going to be able to put it in a garage and just take out teeth because that's all you can do when you're there. And this is supposed to play, I'm not sure. This is supposed to play. This is when I left NHC. The story of the chair holder. This is supposed to be a video. Dr. Tari, what did you not do? I want the volume. Eh? Eh? Go slideshow, I'll go first. So, this is the wrong slide anyway, but it's fine. It's not the updated version. They just took whichever they could take there. But in any case, the essence of it all is sometimes chips can be down. And this is not okay, sharp. So I pick up these things from Facebook and what. So if the other disclaimer is that if these things I don't give credit to the original person who came with the codes, don't blame me. I mean, there are a lot of my audience on social media who are 2000 and they don't ask me a lot of questions. So I buy a lot of dental chairs. So I want to buy some drinks for some people. You must just tell me how many years you think the chair is, and then I'll buy you a drink if you're accurate. Dr. Tari. Okay. That's, I think Dr. Nkumilen has that one in green at the top right. That one there. Okay, let's start top left. Top left. How many years do you think that chair is? Just a quick guess. Anyone? Anyone? Hey, by show of hand, but I have to buy your BMs. Yes, sir. Okay, okay, that is closer. It's 8 years old. It's a Gracia from, it's my first chair that I bought brand new. Okay, probably the only one I bought brand new when I got to Joburg. And then bottom right, bottom left. Anyone? Yes, doc. 5 years. That is a second year chair. If you recognize it from your old practice, sorry, it's fine. Top right. Top right. Yes, doc. Anyone else? Anyone? Okay, there you are cheating because those were not out 4 years ago. So it's a year and a half. We bought it last year, January, from Minas. And then the bottom one, the red one, anyone? It's okay. It's an aged performer. Those who know about chairs, anyone quickly? It's probably 15 years old. Yeah. Anyway, let's carry on. Okay, you know that we've been robbed again. So when I first started working in booking this year, I met these guys and they said they could guard our practice every day when we are in booking. Now they guard our practice every day when we are in booking, so Soweto and Midrand. Every day. The budget on them is a lot. And then we also have a fleet of cars that we use for getting around, and those are company leases and the tax advantages of having those. I actually don't have a car in my name as we speak, because I travel, I work 7 days, almost 10, 12 hours. So I travel between practices, even though there's many of us. Also, I wanted to do a disclaimer because I agree Dr. Tadi and Dr. Mkize are consultants in our practice. So I'm glad they are keeping quiet because somewhere I'm lying, they must just keep their cool. So, okay, passion, it has to exude for you to be able to, even it must show with the patient as well. Some patients say, I come here because you show us passion. So in a group practice, you wish you could train people to say, let's show passion, but it's not something you can train. But over a long time, you can teach it by example or something like that. And then perseverance, obviously, I mean, when I sold my car and I didn't have something to go to work with, I persevered in 2014. Resourcefulness, I buy second-hand chairs and I make them look good. Open-mindedness, already, you know what that means. Adaptability, be willing to adjust, to be agile, be willing to adjust to different circumstances as they come in. Most of us here, we will be able to say, trying a little bit of auto has saved our practices over COVID. Yeah, that's adaptability. You are agile. You make quick decisions. I don't know how, but it happened. So let's look at the business overview. This is not the right presentation, but I'll make do with what we have. The growth history, I'm going to entertain that. We'll do a market analysis. We'll do product differentiation, growth strategy, marketing strategy. This is the boring part of the presentation, the formal part. So there's a saying, I didn't credit the original sayer because I said it happens. This is from social media. So it says if you want to go fast, go alone. If you want to go far, go together. But I go further and say, if you want to go far and fast, take good people with you. Let me show you my organogram and you will see what I mean. You won't see the names of the people, but I lead a team of 40. You wonder who's those 40 people. Okay, the cleaners are included there. So it's a big team. It's a big team. And I forget those positions sometimes. Okay, let me explain what it means. There, it's me there for now, and I wish it is not that for long. And then there's one shareholding director at the moment, and then there are dental therapists. We have 3 dental therapists. We have dentists. Oh, this is good, messed up. Okay, the dentists, we have 2 consulting dentists, 1 orthodontist that does difficult cases, and then we have 7 permanent dentists. The payroll is crazy. And then 2 oral hygienists. And then there's a practice manager who has the MBM on my behalf. And then there's a marketing manager who manages the social media coordinator. There's a team leader for receptionists who falls under the admin manager, along with the team leader for dental assistant. And then there's receptionist, dental assistant, and then there's revenue manager. This is the lady that says Yaskolot. She's Zulu, so she says Yaskolot. And then obviously you can never ask for money in any language other than Zulu. And then there's there it's supposed to say clinical records manager, and then and then there's clinical records office. Basically, these are the guys that if you say, I want this person's pictures, because this person is accusing us of having done something with their teeth, or with looking for an x-ray to do this and that, these people are supposed to give that x-ray within 5 minutes. We've actually, we are inventing our own portal for doing a few things. From the different practices, at the moment when you are in Soweto, when you go onto the computer, when a patient sits in this chair in any of all of the rooms, there's 3 rooms there, we can punch their name and then all their pictures from when they started show up on the computer. So there's an internal portal that does that. But then in the other practices, we are extending the same thing to be on the internet. And then now and then if a patient says, I didn't receive my pictures, you just create a link on the internet for them and then send them their pictures. So it's on the cloud. As we speak, all the records are kept on the cloud anyway. So you are supposed to get them like quick. And then we have, obviously, I told you the equipment is old. So we have maintenance who's on retainer. And then the same guy is a plumber. And then we have an electrician. So in the last 5 years, okay, this is yellow, so it doesn't show up. So 5-year growth history. Okay, guys, those focus on the figures at the bottom there, on the right. This is for the month of October 2017, 2018, October 2019, October 2020, October 2021, October. This is only from medical aid. This is only from medical aid. And the payroll is crazy as we speak. And buying second-hand chairs costs money, so we have to have the money. So notice what we did differently. Social media was already there in 2017. And when we moved, this was our tenure for the first month. This is medical aid only. It's fair to say it doubles when it is cash. So don't ask me if that one also doubles when it's cash. When you add cash, the figures double. So don't ask me if that one goes to almost 2 million because it's another story. So social media was already there. Extra practitioners were not there in 2017. So let's see what it does when you add certain things or certain people. 2018, no no extra practitioners, no extra services, no social. I was doing endo in a crown now and then, and I was even referring the crowns back from the people that send their endos to me to do. So I didn't have a specific person that was doing crowns. Now, here in 2019, the complex where I work from, they handed over the whole dental setup to me and said, I must try and see what I can do with it. Immediately, we introduced social media was still there. Extra practitioners, there was a lady that only does crowns. So suddenly, look what it does when you have an extra set of hands from there to there. This is monthly turnover for the whole practice, by the way. This is now monthly turnover for the whole practice when there was an extra set of hands. So I could focus on the endos and we do all the other things. And then I haven't done a crown in over 2.5 years. So, because she's better. Half the time when I'm doing them, I have to call her to say, is it good enough, the impression or whatever. So, and you'll notice that at the moment, our practice doesn't have a lot of gadgets. We don't have a CEREC. We do have a PenServe in Midrand, and it's a digital one, so it's brand new. But we don't have all these gadgets yet, now, because we're basing it purely on what we can do with our hands clinically. We are trying to go to the next level. I agree, this is what the lecture is about. So we will be going to the next level as soon as we can be recognized by the banks. And you will see the history of how we try to buy everything in the last 8 years, ever since I've been in Joburg. So in 2020, we introduced extra practitioners, extra services. That's when I started doing a little bit of auto. And then I started social media management. Look what it did, all the things that we introduced. And at this stage, we still had one therapist, 2 oral hygienists. That was like October, but the other oral hygienist was new. So it was only on extra practitioners, but even the social media team wasn't as strong as what it is now. Then in 2021, I employed, okay, my budget for the social media team is 25,000 rand. Okay, even more when you include some incentives and whatever. So, and they are performance-based things. So last week we celebrated, 2 weeks ago, we celebrated 20,000 followers on Instagram. So suddenly we're doing a good job because of them. Thank you. So then extra practitioners were introduced. Like I said, now we have 15 practitioners, including 7 permanent the dentists. And this is what happens when you have extra practitioners and you have proper social media management, you have extra services, and so product differentiation, what makes us different from our competitors, or how do we differentiate our products generally? We are in the northern suburbs and we charge medical aid rates. I insisted on that because I worked at the University of NHC for 4 years, and I realized that we were charging cash there, and I could see that there was something that was lacking. When you put something on social media, it's picked up by someone in Kagiso or someone in Alex or someone in Bryanston. But even the black middle class in Bryanston, they say to you, I pay 8,000 on my medical aid with 4 family members. You can't tell me I have to give you cash. They are middle class, they drive whatever car, but they still insist that they would like to do things on medical aid. So that taught me where I can't move around Joburg and say, automatically, everyone has cash in Joburg. So, but then what happens? When it's a hybrid, you still make that 900K on medical aid, and you still make the other 900K in cash. So the best of both worlds. So our price is medical aid based. And then mostly discovery. We even went on to the contracts when we went to Soweto for the sake of expanding our reach within the community, but it didn't work. Because people would want to come to 4 ways and want to be done on Danish contracts because they've been promised that we'll do them on that. So we dropped it. The entire thing, even in Soweto, it's not there anymore. And then you still need to be a good clinician and you still need to give good customer service. All our reviews that you have seen, both positive and negative, especially the negative ones, we actually hold meetings about those reviews and we action them. Whatever someone is complaining about, we try and bribe them so that they don't go public. Then accessibility is Our midland practice, ever since it opened 7 days a week, and we open from 8 to 6. So because we are many, we can do shifts. You can do, even there's people that don't work Mondays, and there's people that start at 8 and at 9 to 5, and then 10 to 6. And then I do the big shift. I start at 8 and I end at 6. So yeah, anyway. So market analysis, competitor analysis. This is our marketing manager basically picked up his phone, called people in a certain area and asked them how much do you charge and da. Then he placed us there in terms of we are conveniently found, we are affordable. Yeah, and our competitors found themselves. They agree we placing them, so we can place them where we want. So, but he did some thorough thinking into that slide. So, and then our target market is middle class of all colors, and shame. Even white people, when they come to you and they like your service, they call their families and everybody. So you can't say you target black middle class, it's suicide. Target everyone that enjoys your service and try and service them as well as they can. Word of mouth is still a good way to bring people back in. So, and then our service offering is we offer everything in our multidisciplinary practices. So there will be people, I haven't done bleaching in my life ever since I was born, but there's lots of bleaching done in our practice. There's veneers, there's everything. And then value proposition is we still give people first world dentistry, even in Soweto, even in Sibukeng, we try our hardest at medical aid prices. And then location is we try and be everywhere. And then we'll be spreading to other localities very soon. Because once you perfect the model, I'll still have one business manager with an MBA. And then I'll still have one marketing manager, and I'll still have one HR manager, whatever. IT, logistics person is busy packing their bags, looking at where they can go next. So, yeah, the slide was updated, but this we can work with. Infrastructure, I mean, over COVID, we are still using our offices. We can't work from home. So you need to have your own buildings at some point so that you can harness the entire value chain so that you don't leak out money. I mean, our rent in 4 ways is 89,000 this past month. And our rent in mid-rent is 51,000, and it goes on. So if you have your own buildings, it makes more sense. So, and by the way, with that kind of rental on a monthly basis, your banks look at you and say, yeah, you can afford what you're trying to talk about. So now try and get your own building if possible. We're working on that. And then fearless marketing, Zota tells me what I must do when she comes to the practice. She says if she's shooting, she says, and then she says, okay, when I'm shooting, I don't wear too much. Otherwise, it's not the same. On TV, I must be Zotwa. And so that's part of our marketing. And we are fortunate to have some of those guys around us. And then there's an element where we use a lot of influencers. And somebody will ask you, do influencers pay for some of the treatment you give them? Simple answer, mostly no. If we are approaching 2 million rand and they're not paying, don't fight with me, please. Honestly, I think we mustn't be penny wise and pound foolish, because we want to ask for a cent on everything. Some bleaching kits come on special, but you want to charge people when you are doing bleaching, and they are exposing you to 400,000 followers. I mean, let's do the maths there, you know. So yeah, I mean, there's growth. I mean, we're also surprised when we find ourselves. But if it was association with social media influencers, then so be it. Everybody wins, you know, including the pro bonos that we do. We do a lot of pro bono dentistry. And then it also gives you brand superiority when you are associated with social media influencers. And then multidisciplinary practices are also mentioned. It improves your profile. What we've done in the last 12 months, social media, increased workforce, we're trying to fine tune our services. My job now in the practice, which is the hardest, I am a floor manager. You know, like your bank manager, you walk in and he asks you what are you looking for, how's your service? That's what I do. And it's very hard because we are trying to find out what we are doing wrong. Because the one thing I ask myself when I go to work or when I sleep and say, today we made 10,000 rand, I ask myself one thing, what could go wrong? You understand? So my job is to guard against what could go wrong. And I physically put myself in a position where I ask patients, what are we doing wrong? What must we do right and whatever. So we're rolling out some infrastructure. We're buying 5 8-deck chairs in January. And because I'm tired of Chinese chairs, yes. Yeah, and then when you make the circle bigger, you can do collaboration over competition. I'm not afraid to approach anyone now because you see the best that they have to offer. I mean, Dr. Tari now does endo at our practice, and he's not a threat to me because I have to focus on other things. So I see the best that everyone has to offer, and so it improves things a little bit. So there are specialists and consultants. It improves your outlook towards business. And then there's more room for growth if you start looking at it that way, because you focus on growth. And for the first time, I hold accountability meetings with my managers. And we kick ass there because we ask the difficult questions. You can't tell us, I'm waiting for email for 3 weeks for quotation or this. No. We want answers. So everyone in their post must be knowing their story. And then there's freedom to network, retention of most revenue and multidisciplinary practice. I did say about it. So growth strategy, January 2022, we are moving to a bigger practice in 4 ways. Actually, the other presentation I have has the map of where we are going to, I mean, the actual plan. We are installing 7 chairs in the new practice in 4 ways. So it will be now 19 chairs on top of the 3 that we already have in 4 ways. And then I would like to work in Durban. You see, we work for the job, but the job never works for us. So I like Durban, so I want to work in Durban. So let's see if that can happen. And then Cape Town and there's a lot of our patients that fly in from Durban for several services, including motor. And then Cape Town, there's a lot of our patients that travel between Cape Town and Joburg for whatever reason, and then on work, and then we can service them better if we can have. So now this is an interesting part. Between 2013, obviously when I sold my car, I got some change. So I was using some of it to put back into the practice. And there was Uber, so I was able to Uber. And luckily the children's school was closed, so I didn't need a car for a few months. And I did buy another second-hand smaller car. So, and then you can get personal loans, but you can't. My business is an Inc. And then Sunset Dentistry is actually a PTY. So anyone can invest in Sunset Dentistry. So some of the stuff, yes, we are practicing, doc. Some of the formal stuff we are trying to. So that way, even a share scheme for staff, and then even a big investor from outside. So Sunset Dentistry focuses on capacitation. We can do feasibility study, marketing, we can do HR for you, we can do accounting, we can do all these things, and we can do business plans and whatever. And then we mainly own the equipment. That's the idea. It owns the equipment. Then the Inc. doesn't own the equipment. So someone said we could manage our affairs better that way, tax, depreciation, this and that. Now I have 2 accountants because I don't know these things. So the one accountant does compliance, all these COIDA things and whatever. The other accountant actually does internal systems with every department. And something that he made me aware of is that when you have an ortho patient that pays you a deposit of 5,000 and they owe you, let's say, 20 for the next 10 months, that's actually income that you can project in your books. I don't know if you were referring to something like that, Doc. You were talking about selling your debt, but that's what I thought you were referring to also. Because he told me that if you don't show this to your bankers to say they can give you money based on, if it's 20 patients and they all owe you an extra 2,000 times 10 months times 20 patients, it's a lot of money. You know, that, and you've already installed the braces. It's not like you are starting a business. You are expecting that money. And then they ask you also, what's your default rate on this money? If 2% is your default rate, it means 98% of that money you're going to get. So you can put it in your books and factor it in. So he says, if you want to stop buying Chinese chairs from your colleagues, then you must do those things so that, so the accountants are busy working these things out to see. I don't know if I'll stop buying Chinese chairs because anyway, so personal loans, I was able to raise a lot of personal loans and to put into the business, and you pay them back. And then, but for the first time this year, I was able to raise some loan for the business, and yeah, the business is starting to be recognized by the banks, so it's a good thing. Then I'm hoping to sell shares one of these days, and then from 2021, which is this year, and going next year, I'll still be using institutions' money, but then one day we'll sell shares and then do the right thing. And then, no matter the gimmicks and strategies, you can't put a good practitioner down. You still have to be a decent practitioner. You can be as popular on social media, but then that's gonna come back to bite you because the guys are gonna say exactly what they found when they came to your practice. We get that a lot, but you win some, you lose some, you know. And future endeavors. This is the building that we're occupying is from the 1st of February. It's opposite the building where we are. Oh, this is the map. Okay, it has changed a little bit because in the corner there, as you walk in, this whole building is partitioned with glass. So when someone is standing there, they can see someone there. And this is X-rays here, and then this is sterilizing here. We just use we don't use a room, we use one nice shelf that's clean. And then my partition, some of it is in glass. Okay. No, thank you yet. So this is 7 rooms. It's 1, 2, 3, 4, 5, 6, 7. And just a technical thing, for rooms like this, we use 2 sets of compressors and 2 sets of suctions, because you don't want the whole practice to be down. Mostly in our practices, we have 2 wings. Each wing has separate, even in those wings, you can find, if it's 4 chairs, 2 of them have their own compressor, 2 of them have their own suction. So you are never completely down. And there's generators in most of these buildings anyway. Even in Soweto, we have our own generator. And then this is Dr. Minga, my partner in crime for the last 8 years. All the good work. He's taught me a lot on health messaging, introduced me to a lot of people in Joburg. He even introduced me to Dr. Mkize. And we've got a show called Ask Your Doctors. We're shooting 4 episodes tomorrow, and it's online, but it's TV ready, so it's 24 minutes of episodes that you will be seeing it on YouTube, but hopefully not for long because we've got an entire production team, makeup artists, everybody, because we are trying to make it TV quality. What it does, tomorrow we're discussing men's health. We're talking about in anticipation, we're talking about World AIDS Day. We're trying to make health messaging more audience-based, where we don't come up with a topic and give it on radio. We've done enough of that. We're coming up with a platform and we say to people, there's our topics online, ask us questions based on those topics. And then they give us questions, and then obviously not personal consultation things, which is the first thing that we will try to do. So we are shooting 4 episodes tomorrow. Wish us luck. So we're not going to have a lot of drinks today. And this is something I hope to do on all Wednesdays from now on. From January, I'm going to work 7 days. So I cut the Wednesdays. So some Wednesdays we'll be shooting, some Wednesdays I'll be doing nothing. And okay, that is that. Oh, by the way, and there's actually another slide that was omitted. It's in the other. It actually shows you the breakdown of the amounts that I was showing you, but it only shows you the first amount, yeah, 37,000 in October 2017, and the 900K in October 2021. But what it does, I can tell you the figures as they stand. We had rejections of about 40,000. You know, they will on the switch report that comes every month. It will tell you this is where you made mistakes. But predominantly, the code that is top this month is 8890, which is the follow-up claims for auto. And the second one is about 139,000. And then the follow-up code is 88, which is but lab crowns. It's 8099, whatever. And then the crowns are about 100,000. We should have gotten a SEREC like 2 years ago, but because of financial stories where the banks tell you stories, I've tried ordering, didn't get. And then the other significant thing is you can make that amount of money with medical aids questioning you as little as possible. We don't have to be going underhanded for us to get that money, because people say medical aids, once you make a certain amount, you make about 450,000 out of discovery alone, about 160 out of gems, but they have not come knocking on our doors. So it can happen. I'm just saying it's important to know that they're not going to question you once you jump 200,000. Go ahead and jump that 200,000. I mean, they say, how do you make this much? We say, these are the pictures of the people that are working in our practices. It's legit. You know, so it can happen. Thank you. Any questions? Yes, Doc. You're welcome, Doc.
At what point do you charge your patients after hours or on your, because I'm just a bit concerned with the working on Saturdays and Sundays after hours. At what point do you charge your patients?
The little that I can remember, he said, if it's normal working hours, you're not supposed to charge. Yeah, no. Yeah, but then what happens is, in fairness, there are guys that don't work Mondays at all, because Mondays are Sunday. So we don't charge extra. Yeah, but it's a shame. Next year I won't be working as hard. Yes. No. The agreed balance billing would be your statement comes out the way it is, and the patient doesn't have split billing is when you take the co-payment on outside and they pay it extra. Yeah. So no, we just invoice at discovery rates. Everything. Yeah. Yeah. The GEMS patients are so few, you don't want to trouble them. So, I mean, it's majority discovery. By the way, Dr. Tari, when he worked at our practice, he found that our prices are a little lower than, because I wasn't focusing on that part of the business. It escaped me. So he's teaching us how to claim now at good rates and account for everything that we use. Yes, Doc.
Isn't it wise for us to have to say in your sunset, your 83680 is 400, doesn't matter.
Yes.
If your discovery patient they pay 390, the patient will pay the 10 rand. If your gem pays 200, then they will pay a balance of 200 rand. Would it be wise like that, or you prefer to have change your fee based on which
Doc, the guy that parks a 5 Series, average higher middle class person in your suburbs, that is expected to pay that 10 rand extra. They will not fight you based on the fact that they don't have it. They will fight you based on principle. And you will have lots of fights in the reception. That 10 rand is not worth it. That's what I feel. And the guy just comes out aggrieved. He says, I'm not coming back here. because they're fighting me for 10 rand and yes, sir.
Dr. Mugwet. Dr. Odi, look, I'm gonna be Dr. Sincero for now. We need to attend another session, very important session. I know we have a lot of discussions. We can meet Dr. Mugwet, I know. Yeah. I mean, later, there's a, you know, the DPA again. So the proper one, then the Rabua, Hasidays, everything. You can meet here if you want to come here. Yes. But remember, business model you should deliver this conference. You don't want to skip this important session. So hold on. Dr. Mugwet, we appreciate you for coming and honoring DPA. And thank you very much for giving us this food. You can see a lot of people, they are still eating. They want to eat some more. So the circle is bigger and bigger. The good part is I'm in the middle of that circle. So thank you very much.
Thank you, Doc.
All right. So from here, we'll go directly to upstairs for the award ceremony, so that we can finish off with the award and the good parts. Yeah.
Thanks, guys. Let's do it quick so that we're already out of time. So yeah,
So much.
Oh, yes. Yeah, 80%. It's a good one. That's your cable, right? Oh, and a router. Brother, give me a router there. Okay, Mamzo, please 42%, not bad.
Thank you so much.
Okay, cheers. Your dad has been calling you. Yes, your papa. But I told him he's still robbing the bank, so we'll be back. Hey. Camera's down, eh? Oh, okay.
As dental professionals, we dedicate our lives to protecting our patients' health and well-being. But who looks after us? Dental Protection does.
Their expert dental legal team are dedicated to protecting us and providing reassurance when we need it. Dental Protection was started by dentists for dentists. Their unparalleled expertise gives me confidence, and I know they will support me throughout my career. And because they are owned by members like me,
Protecting your career and reputation, now and into the future.
As dental professionals, we dedicate our lives to protecting our patients' health and well-being. But who looks after us? Dental Protection does.
their expert dental legal team are dedicated to protecting us and providing reassurance when we need it. Dental Protection was started by dentists for dentists. Their unparalleled expertise gives me confidence, and I know they will support me throughout my career. And because they are owned by members like me, I know they will always put me first.
No one is in a stronger position to protect me if I need advice or face any challenges in my career. And they help with more than just patient claims, including issues such as unwanted media attention, criminal proceedings, ethical dilemmas, and regulatory issues. If I'm worried or in trouble, I know I can call on them and speak to their team of experts in an emergency at any time.
But it's not just about if things go wrong. The team at Dental Protection helped me stop problems arising in the first place by helping me look ahead and understand risk for myself. I've got access to a huge range of online courses, seminars, and podcasts just a click away, plus workshops and other CPD accredited programs too.
Discretion means that Dental Protection are flexible and adaptable. They treat each incident on an individual basis, giving me access to protection for a wider range of situations. And Dental Protection gives healthcare professionals like me a voice, representing my interests to the government, policymakers, and professional bodies.
So whether you're an existing member or part of the next generation,
Dental Protection is here for you, for me, for us all.
Protecting your career and reputation, now and into the future.